السلام عليكم. إن شاء الله الصيام مقبول. On behalf of the organizing committee and scientific committee, I would like to welcome you to the second day of this symposium. Today we have around 6 presentation. The first one will be about blood pressure and obesity with Dr. Anthony. Second one, a practice of cardiac rehabilitation with Dr. Eli with me. The third one, physical assessment with Dr. Anthony. The fourth one, pain management for stable and unstable angina with Dr. Anthony. The fifth one, hemodynamic monitoring with Dr. Anthony. And the last one, myocardial infarction definition and treatment, also with Dr. Anthony. Dr. Anthony, we can start with you with the blood pressure and obesity. Thank you.
Thank you, Dr. Eli, and hello for everyone. So I will share my screen. Are you hearing me well?
Yes, yes. Yes, okay. For me.
And can you see the slides?
Yes, okay. Yes, everything is good.
Okay, perfect. So I will start with the first topic, which is hypertension and obesity. So as you know, the prevalence of obesity measured by BMI, body mass index, has risen to unacceptable levels in both men and women in the United States and worldwide in the recent years. So we have a tendency to see more obese people year after year. So we consider now obesity as a global epidemic. So it's like a disease. So it's now considered an epidemic or even a pandemic. So affecting nearly all countries in the world. So you can see here the top 10 fattest countries in the world. You can see that the United States is number 1, mainly due to the diet they use, the fast food. China, India, Russia, Brazil, and fourth, Mexico, Egypt, and Germany, Pakistan, and Indonesia. These are the top 10 countries with the highest rate of obesity. So what does obesity really mean, and how is it's associated with cardiovascular disease? This will be the main focus on our study. Will focus on obesity and cardiovascular disease in general, and then we will focus on obesity in relation to hypertension. So as you know, the body composition, we have the total body mass is composed of 2 components. We have the fat mass, so the fat composition of our body, and we have the fat-free mass, so the muscles or the bones, the water and the viscera, so the organs, the bones and muscles. So we have 2 components. So our bodies are made up by fat-free mass and fat mass, as we said. So fat-free mass includes bone, organ, tissue, and water, and we cannot change the part of our body that is bone, tissues, and organs. For sure, we can't reduce this type of So we need to work on reducing the fat mass, because we can work on it and we can reduce it. As you can see here, an example, you have here a 2 kilogram of fat, and you have 2 kilogram of muscle. You can see that the volume of the 2 kilogram of fat is larger, but both have the same weight. So 2 kilogram of fat is soft, lumpy, and sits right under the skin, and it takes up around 3 times the space on the body as 2 kilogram of muscle, which is tightly packed and close to the bone. So you can see that fat will give us obesity, but increasing our muscles will not give us obesity, but will increase our weight the same way as obesity. So we have, when we talk about fat, we have 2 types of fat. We have the visceral fat and we have the subcutaneous fat. The visceral fat, sometimes referred as deep fat, it's the fat that grows the inner abdominal organs like the stomach and the liver. So the fat that we cannot palpate it, it's deep, it's around the organs. not under the skin. The fat that we can palpate under the skin is called the subcutaneous fat. It's located right under the skin. And the subcutaneous fat is not responsive to good diet and exercise. So so you can see here in the figure, you have the subcutaneous fat, which is superficial, and you have the visceral fat, which is more deep. So the visceral fat contains higher cardiometabolic risk. So when we have visceral fat, so fat around our organs, we increase the cardiometabolic risk. But when you have subcutaneous fat, we increase the cardiometabolic risk as well, but it's lower than the visceral fat. So the visceral fat is the culprit fat. So it's the fat that's causing all the diseases and all the cardiac manifestation, the hypertension and other manifestations. So we need to work on reducing the visceral fat component. So you can see here when we have obesity, as you can see here, you will increase the inflammation inside those cells. So we have inflamed adipose tissue and blood vessels due to high fat. And when you have inflammation, we will have insulin resistance. Insulin resistant is a state of prediabetes. So it increases the risk of type 2 diabetes later on. And inflammation as well will manifest the blood vessels and will cause atherosclerosis, which is narrowing of the blood vessels. And this will lead to coronary artery disease if affecting the cardiac vessels, or it will lead to other vascular diseases in different organs if affecting other than the heart. So it will lead to established cardiovascular disease. So if you see here on the image on the left, where there's no fat, so we have less inflammation, so we have less insulin resistance, and we have less atherosclerosis. So we have less diabetes, and we have less cardiovascular disease in low fat ratio. So how do we measure obesity? How can we say that someone is obese or someone is not obese? We have to measure the waist and hip ratio. So we measure the waist ratio. It's just under the lowest rib. So you can palpate your lowest rib, and if you want to measure your waist ratio, you can measure it directly under the rib, as you can see on this image. And if you want to measure the hips ratio, so it's a hip measurement. It's as you can see it on the image. It's just is directly on the hip anatomy. So, and we divide the hip, and we divide the two measurements in order to get the ratio. And for women, the ratio should be less than 0.85 to say that it's okay. And for men, the ratio should be less than 1.0 normally. So to define obese patients, we can measure waist, hip, and ratio, and we have the numbers. If we have higher numbers, so we can say that we have obesity. So you can see now in this figure, so when does the waist circumference become a risk? So you can see that the goal value of waist circumference, so when we measure the area under the last rib, it should be less than 94 centimeters in men and less than 80 centimeters in women. When we have this number, we have no risk of illness due to overweight. So we have very low risk of developing cardiovascular disease related to fat if we have these numbers. But when we have in men a waist measurement of 94 to 101 centimeters, and in women 80 to 87 centimeter, then in this case we have a slight health risk, slight increase in cardiovascular risk. So we should avoid for this patient excess weight gain, or so we need to work on dropping our weight in this case. But when we have waist in men that's above 102 centimeters, like you see in the third image, and above 88 in women, in that case, we have a significant health risk. And here we should drop the weight and seek for a specialist in order to help us drop our weight. So it's very important to measure the waist circumference in our patients, especially diabetic patients or cardiac patients and overweight patients, in order to define the risk for them. This will motivate them to lose weight, because if we say to our patients that he has a significant health risk and we give him a number, rely on. So the patient will be more motivated to drop his weight. You can see here in this image that we can also measure BMI. BMI is the weight divided by the square root of height in meters square. So BMI is not a good index of adiposity, but it might be a good index of cardiometabolic risk. So it does not estimate the amount of fat we have, but when BMI increases, the cardiovascular and metabolic risk will increase as well. So if you see the normal BMI is between 18.5 to 24.9, as you can see on the first image. It's normal weight, but when we have BMI between 25 to 29.9, we can call it overweight. It's not yet obesity, but it's called overweight. When the BMI is between 30 to 34.9, it's called class 1 obesity. So it's considered here obesity as a disease. And when a BMI is between 35 to 39.9, it's become a class 2 obesity. And when BMI is between 40 to 49.9, it's considered class 3 obesity. We have some cases of BMI of above 50 kilogram per meter square. These are super obese patients and considered class 4. And BMI above 60 kilogram per meter square, which are considered super obese patients. These are class 5 obesity. And you know that it's very used. BMI is very used. You hear about BMI a lot. It's the most used parameter in the literature nowadays, and it's a strong predictor of cardiovascular disease and cardiovascular mortality, as we said. So people that are overweight or obese, they have more risk factors to develop cardiovascular disease at an increased risk of a lot of cardiovascular disease like hypertension, CAD, heart failure, and atrial fibrillation. So we need to prevent development of the disease by dropping the weight before late stages. So we will now talk about the overweight and obesity. You can see here on the graph that you have when you have patients with normal weight, you can see that the blue curve is for men and the yellow curve is for a woman. So when we have normal weight, you can see that the relative risk of cardiovascular disease is very low. It's between 1 and 1.4% of risk of mortality if we have a normal weight, so mortality from cardiovascular disease. But when we become overweight, so when our BMI becomes between 25 to 30, we can call it overweight. You can see that the risk of cardiovascular disease mortality will increase, and you can see the curve is going up. And when the BMI increases above 30, though, so when we have obesity and severe obesity, you can see that the risk of mortality becomes increase more significantly. More in men more than in women. So we can see that the mortality from obesity and cardiovascular disease is more important in men, especially very obese men, as compared to very obese females. And this is related maybe to the hormones, estrogen and progesterones, which are protective, especially for patients with age below 50, females below 50. So the cardiovascular disease mortality and morbidity is elevated, as we said in the previous graph, in overweight patients, and particularly patients with central deposition of adipose tissue, because as you know, some patients have central obesity, so they have fat accumulating in the abdominal area more than other areas, and this is a higher risk than fat that is distributed moderately in different parts of the body. And the abdominal obesity has been shown to be a risk for CVD worldwide, so risk for cardiovascular disease worldwide, and it may be associated with a lot of comorbidities like hypertension, hyperlipidemia, diabetes, insulin resistance, and elevated level of fibrinogen and C-reactive proteins, so elevated level of inflammatory markers. Fibrinogen and C-reactive proteins are inflammatory markers, so when they are elevated, as we said before, they increase the risk of platelet activation and increase the risk of thrombosis, increase the risk of vascular disease and coronary artery disease. So it's so obesity is an inflammatory disease and increases the risk of a lot of other conditions. So you can see here when we are obese and when the obesity increases, we have increase in myocardial infarction rate, as you see in this curve and in this line, it's going up when the BMI goes up. So the myocardial infarction increases with obesity in this study. Same here for stroke rate. So cerebrovascular accident, it's a risk of obesity is also a risk factor for cerebrovascular accidents. So we have increase in rates of strokes when the BMI goes up. So it's proportional. Stroke risk is proportional to BMI, as you can see on this line that is going up. So the mechanism of obesity and cardiovascular disease. So obesity is a pro-inflammatory state, as we said. So pro-inflammatory state is a pro-thrombotic state. So it increases the risk of platelet activation and thrombosis. The obesity will also cause mechanical effects on increased weight on chest wall. So we'll have increase in chest, fat. So we have decrease in lung compliance. So we'll be prone to develop obstructive sleep apnea as we increase our fat in this chest and in the neck area. And obstructive sleep apnea, as you know, is a risk factor for developing arrhythmias, cardiac arrhythmias, because of the low oxygen delivery to the heart. So we will have risk of atrial fibrillation, which is a natural arrhythmia. We'll have an increase in cardiac workload. We'll have a restrictive cardiac filling pattern. All of this is due to the accumulation of fat in the chest region. And when you have increase in cardiac workload, so the heart will pump against a higher pressure, the muscle of the heart will become thicker. So we have hypertrophy because the heart is working against a higher pressure. Exactly as, for example, when you do gym workup or do to increase our muscle, we are putting tension on our muscle in order to become the muscle become hypertrophy. Same thing happen in the heart. The heart will become hypertrophic. And all of this, the arrhythmias and the heart hypertrophy will end up leading to heart failure. So obesity is a direct risk of developing heart failure. Obesity is also can cause metabolic syndrome like insulin resistance, as we said, which is a pre-diabetes condition, and if left untreated will lead to hypertension, dyslipidemia, and will lead to diabetes. And as you know, all these conditions, hypertension, hyperlipidemia, and diabetes, are a risk of acute coronary syndrome. Acute coronary syndrome is as well, if untreated, will lead to the development of heart failure. So atrial fibrillation, left heart hypertrophy, and acute coronary syndrome are all a side effect of the diabetic pandemic, the obesity pandemic. So they all will lead to heart failure, which is a fatal disease. Okay, so now moving to hypertension and obesity. Hypertension is linked to obesity because we will see in the next slides the blood pressure mean is in obese patients is a lot higher than non-obese patients. So more than 30% of US adult population is obese, have a BMI of above 30. So any weight gain, even to the level of that is not obese, so between BMI between 25 to 30, even this level of BMI is associated with increased risk of high blood pressure. And BMI above 30 is a significant predictor of incident hypertension. So it's very rare to see a patient, for example, with a BMI of 35 without high blood pressure. Most of them have high blood pressure, and the hypertensive effect of weight gain is related to increased abdominal visceral fat, and we'll see why later on in this presentation. So obesity and hypertension, as you can see in this slide, when in this study, this was a study that was published. As you can see that when the BMI increases, so moving from 20 to 30 to 40, you can see that the percentage of patients having hypertension becomes higher. So it's proportional. So for patients with BMI of 35, 40% of these patients have established hypertension, grade 1 and grade 2 hypertension. And most of them have elevated blood pressure. Elevated blood pressure means blood pressure between 130 and 140. So most of them will have blood pressure above 130, which is a risk factor also for cardiovascular diseases. So the mechanism of obesity leading to high blood pressure is very complicated. We have a lot of mediators related to that. We have the leptin pathway. We have the activation of the sympathetic nervous system. Sympathetic nervous system means the secretion of more epinephrine and more norepinephrine, which will cause vasoconstriction and leading to positive increase in blood pressure. And endothelial dysfunction, which is directly related to obesity, is also linked. Nitric oxide is also linked, and we'll see that the kidneys is also linked. We'll see that later. So when we see obese patients and we do electrocardiogram, so to see if the heart activity of these patients, we do an ECG in obese patient, we can notice that obese patients tend to have increase in heart rate. So they have heart rate that is higher in average. They have increase in PR interval. The PR interval is the on the ECG, the PR interval reflects the atrial contraction in these patients. So we have an increase in PR interval. So meaning that we can have increase in AV block. We have increase in QRS interval. So the QRS will become wider in this patient. When you have decrease in QRS voltage, the decrease in QRS voltage is related to the fact that the distance now between the leads that we put on the chest to do the ECG and the heart becomes wider because of the fat. So this will be reflected on lower voltage on the ECG. The amplitude of the QRS complexes will become lower. And we can see we have a lot of other changes like increase in QT corrected interval, increase in you have in ST and T wave abnormalities, ST depression. We have heart axis changes. So because of the fat and the increase in the distance between the electrodes and the heart, we can have deviation of the axis of the heart. We can have left atrial abnormalities, and we can have a lot of modifications in obese patients. So the duration of obesity may also affect our heart disease. So for example, every 2 years additional lived with obesity, the risk of cardiovascular disease mortality will be increased by 7%. So obesity is a long-term disease. And you can see that if we stayed obese for just 2 years, we increased our cardiovascular mortality, long-term cardiovascular mortality by 7%. So the delaying of onset of obesity can contribute to lower the risk of developing future cardiovascular disease. So it's very important to prevent obesity, especially in young patients, because because young patients with obesity will have increased 7% mortality later on at an older age. So it's very important. Okay, so can you? Some patients will ask us if even if they are fat, can they be fit? So in this context, we will focus on the fat but fit paradigm, which refers to those individuals whom, in spite of being obese, they have a relatively good cardiovascular fitness level. So not every obese patient is a sick patient or is a patient that has increased mortality. A lot of obese patients are working on their fitness level and working on the physical activity level, so we can have a relatively healthy obese patients, and we see that. So when we talk about obesity, we need to talk about the metabolic syndrome. The metabolic syndrome, as you know, contains 5 variables. Contains 5 variables. So the dyslipidemia, to have a metabolic syndrome, we need to have these 5 criteria. We need to have triglycerides above 150 milligrams per deciliter. We need to have HDL cholesterol in men that is less than 40 and less than 50 in women. We need to have a fasting glucose of above 100. So we need to have a degree of insulin resistance, pre-diabetes. We need to have an obesity in a man by measuring the waist circumference, as we said earlier in this topic, above 102 centimeter, and in women above 88 centimeters, and the blood pressure should be above or equal to 130 over 85 millimeter mercury. So we need to have these 5 criteria, 3 out of these 5 criteria, so 3 or more, in order to have the metabolic syndrome. The metabolic syndrome is a risk factor for cardiovascular diseases. So you can see here the metabolically abnormal versus metabolically healthy obese. So as we said, we can have healthy obese. So the metabolically unhealthy obese, we call them MUO. These are 70% of obese. So 70% of obese are unhealthy obese. So to be classified as MUO, metabolically unhealthy obese, you need to have BMI of above 30, plus you need to meet 1 to 4 of the we need to meet from 1 to 4 of the metabolic syndrome criteria. So we need to have criteria from the metabolic syndrome plus a BMI above 30 in order to say that the obese patient is unhealthy. While 30% of obese individual, as you see on the second image, are metabolically healthy obese, and you call it MHO obese. So to be classified as MHO, you need to be obese. So definition of obese is BMI above 30, but we need to have 0 from the metabolic syndrome criteria we saw on the previous slide. So we need to have 0 from these criteria in order to be obese but healthy. So the metabolic status, as we said, we can have metabolically healthy or metabolically unhealthy. The metabolically healthy can have a normal weight, so BMI less than 25, or it can have an increase in weight and BMI of above 30, and we call it, as we said, metabolically healthy obese. So for the metabolically unhealthy, we can have normal weight and we can have obese patients. And for obese patient, we said we call them metabolically unhealthy obese, MUO, as we said on the previous slide. So the metabolically healthy normal weight is a low risk. So patients that are not obese and don't have any of the metabolic syndrome criteria, these are classified as low risk patients. While patients that have intermediate risk, meaning that they are metabolically healthy but obese, so BMI above 30, but no metabolic syndrome criteria, and metabolically unhealthy at normal weight, so normal BMI, but they have criteria for metabolic syndrome, these are at intermediate risk. So even for healthy obese, there's a risk to develop cardiovascular disease. So it's an intermediate risk, the metabolically healthy obese. It's not a low risk. And the high risk are the metabolically unhealthy obese, so the patients that have a BMI of above 30 and have criteria for metabolic syndrome. Okay, so the metabolically healthy obese, MHO, we said BMI above 30, but they don't have dyslipidemia, they don't have hypertension, they don't have type 2 diabetes, they don't have even pre-diabetes, and they don't have any criteria from the metabolic syndrome. These patients are predisposed to increased cardiovascular disease just from fat and from inflammation that is caused by fat. So fat will increase the risk of coronary heart disease by 49%. So 49% higher risk to develop coronary artery disease, even if healthy obese, and 7% increased risk of cerebrovascular disease, and 96% increase in risk of heart failure. So it's a huge risk factor for heart failure. And this was published in the Journal of American College of Cardiology in 2017. So it's a recent article published in one of the top cardiology journals. So you can see here that we need to treat these patients. So how can we treat? So for patients that have a BMI between 25 to 30 kilogram per meter square, for these patients, first of all, we need to do lifestyle modification. Before doing any medical treatment or before recommending surgery, we need to start with diet and physical activity, because they are in overweight. They are not obese yet, because we said that BMI between 25 to 30 is considered overweight. So for these patients, we do lifestyle. For patients with BMI of 30 to 40, meaning that patients that are obese, then we can propose to these patients pharmacotherapy. So we can give them some medications. And for BMI above 40, bariatric surgery, so we need to do surgery for obesity. We have also cases that we do surgery for BMI between 30 to 40. We'll discuss it later on in this session. So the benefit of weight reduction on cardiovascular system. When we reduce weight, we will reduce the blood volume. So we'll reduce the the volume. So we'll decrease the risk of developing heart failure. We reduce the stroke volume. We reduce the cardiac output. We reduce the pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure is usually elevated in patients with heart failure as well. So losing weight will drop the wedge pressure, and we will decrease the left ventricular mass because we will decrease the left ventricular hypertrophy, and we will decrease the oxygen consumption. We will decrease arterial pressure. We will drop the blood pressure. We will decrease the filling pressure of the right and the left side of the heart, and we will decrease the resting heart rate because we said before that obesity will tend to increase our heart rate, will increase in oxygen demand on the heart, so increase in myocardial ischemia. So dropping weight will drop all these conditions as well. So it will drop cardiovascular disease in general. So despite the presence of obesity, sustainable evidence of weight loss among patients with cardiovascular disease who are obese, especially when associated with increase in physical activity and cardiovascular fitness levels. So weight loss is very beneficial for all these patients, and we need to treat obesity seriously because, as we said, obesity is now considered as a disease, as it's a pandemic. So it's a disease that is present in nearly all countries in the world. So now, what is the role of bariatric surgery on weight loss and on heart function? So a weight loss recommendation. We have for patients that have a BMI of above 25, they have for patients that have increase in waist circumference, that patients that have more than 2 cardiovascular risk factor, and they have other comorbidities. For these patients, we need to ask them to try to lose weight. So any of these conditions should raise a suspicion for the physician to ask his patient to lose weight. So you can see that when we have a BMI, when we can propose surgery to treat obesity. So surgery is proposed for patients that have a BMI of more than 27.5 with uncontrolled diabetes, meaning that the patient is on multiple diabetic drug and on insulin, and his diabetes is unable to control it. So even if BMI above 27.5, we can propose bariatric surgery because bariatric surgery was shown to drop the blood glucose level. If the BMI is above 32.5 with no comorbidities, we can also propose the option for the patient to do a bariatric surgery. So we need to have other comorbidities like hypertension, like diabetes, like coronary artery disease, and any other condition. Then we can propose a bariatric surgery. And if we have a BMI of above 37.5 with no comorbidities, we can also propose bariatric surgery, even if we have the patient is obese but is healthy. So because we said healthy obese are at intermediate risk of developing cardiovascular disease, so we need to try to drop the BMI. So the weight loss diet. So if we just do diet, we can have weight loss diets. In non-diabetic, it's better to use low-fat diet for at least 6 months. In diabetic, it's better to use low-carb diet, give better outcomes. And in pre-diabetes, we need to use better quality carbs and low carbs in general to improve outcomes. So this is the recommendation for weight loss diets. Okay, so to reduce the risk of hypertension, dyslipidemia, and diabetes, the lifestyle changes alone is beneficial, but a lot of patients tend to relapse after 1 year of weight loss. We can see that a lot of patients tend to lose weight, then suddenly they have increase in weight again. So most popular diets and or medicines or drugs are not associated with a successful weight loss. That's why we are nowadays pushing patients more in order to perform the bariatric surgery, because bariatric surgery can cure a lot of these comorbidities. It can cure hypertension, it can cure dyslipidemia, it can cure diabetes. So we have multiple types of bariatric surgeries, but these three types are the most widely used. You have the sleeve gastrectomy. You have the so sleeve gastrectomy is when we remove part of the stomach. We remove a part of the stomach, so we reduce the volume of the stomach. This will lead to reduction of appetite. We have the second type, which is the Roux-en-Y gastric bypass. It's a more complicated type of surgery. It's also lead to decrease in weight, and we have also the mini gastric bypass. It's here it's also it can lead to new formation of a new stomach, as we call, and it can lead to weight loss. We can have a less invasive procedure by endoscopy. The other procedures we discussed are surgery, so they require the usage of anesthesia. We can use here the endoscopic procedure, so we go by the gastroscopy tube, like the normal gastroscopy, and we put a balloon inside the stomach and we inflate the balloon. This will reduce also the cavity volume and will lead to decrease in appetite. We can do also the gastroplasty. All these procedures have a goal of reducing the size of the stomach cavity, leading to reduce in appetite. So here is a study. It's an Indian study. It was published in the Obesity Surgery Journal. You can see that they compared the sleeve gastrectomy to the Roux-en-Y gastric bypass. So these two widely used procedures. After 1 year, they confirmed that patients that had a sleeve gastrectomy had 87.6% weight loss. So it's a high number. But patients with Roux-en-Y gastric bypass have 97.2. So it was more effective in reducing the weight. And it was also confirmed 3 years later. So 71% weight loss in sleeve gastrectomy 3 years after the surgery, as compared to 85.8% in the second procedure, which is Roux-en-Y gastric bypass. So in the study showed more benefit with the second procedure. Hypertension at 3 years in the same study, for the sleeve patient and for the bypass patient. So it shows that 55.2% of sleeve patient stopped all hypertension medications after 3 years. So hypertension was cured by this surgery. While in bypass patients, 80% stopped bypass. And you can see that the number of bypass patients is lower, which this is a bias in this study. So the numbers in real life are not exactly the same. And 13.4% in sleeve reduced medication. So they were on double therapy or triple therapy for hypertension. Now they are on just a single medication for hypertension. And 31.3% in sleeve had no improvement, while just 10% in bypass patient had no improvement. So the improvement is more with surgery as compared with no improvement in both types of surgeries. So cardiovascular disease, bariatric surgery will surely affect cardiovascular disease. So if a patient has can have a remission of his risk factor of cardiovascular disease, so 73% will have remission or decrease in the need of insulin for diabetes. 63% will have cure or decrease in medication to treat hypertension, and 65% will improve their hyperlipidemia. Will have a decrease in mortality on long-term mortality by 40% by doing bariatric surgery, and this is a significant number. So as you can see here, it's a case of a patient that had diabetes and has sleep apnea, so it's has snoring at night. So she was a high-risk sleep apnea patient that has a high blood pressure. You can see here after the bariatric surgery, she had a sleeve gastrectomy. You can see that she dropped her weight from 91.2 kilograms to 62.2 kilogram, and her obstructive sleep apnea was cured after the surgery because we reduced the fat of the neck area, we reduced the airway obstruction, and the diabetes, she was on insulin therapy. Now she is just on medical therapy of drug, per-os therapy tablets, and her blood pressure was significantly improving. So we have 5.7 million patients that are obese, so have a BMI of above 30. So 40% are considered obese. So the primary prevention for the patients that undergo obesity treatment obesity without treatment will increase the risk of heart failure by 5 times. So treating obesity and treating heart failure will reduce this risk by 5 times. As you can see, this is a study published also in a cardiology heart journal in 2017 for angina. And in this study, they mentioned that 8.2 million of US patients have and reports angina, and 22,000 hospital admissions are due to angina. Angina, which is a chest discomfort or chest pain. So doing bariatric surgery for patients that never had angina, so for primary prevention of angina, doing bariatric surgery for obese, we can see that just only 0.4% of these patients would have angina later on, versus 1.8% in patients that are obese and that does not do a bariatric surgery. So we have a significant angina prevention when we do bariatric surgery for obesity. While secondary prevention, so meaning that patients that already have angina and obesity, and we treat them with bariatric surgery, you can see that the hospitalization will be reduced by the 2/3. So we'll have a significant reduction of hospital admission when we treat patients that have angina and have obesity with bariatric surgery. Here is another study also published in the Circulation Journal in 2018, which is a high impact factor journal about high blood pressure. And you can see that the primary prevention, so patients that does not have hypertension but have obesity, when we do bariatric surgery, we reduce the risk of developing hypertension later on by 50%. So it's a big improvement. And for patients that already have a hypertension and have obesity, so secondary prevention in this case, we can notice that after bariatric surgery, 84% of patients will have improvement of their high blood pressure, and will have a reduction of 30% of antihypertensive medicines after bariatric surgery, and around 51% will have remission, so no need for medication after the bariatric surgery. And this was a study that followed patients over a period of 12 months, so 1 year. Now, the risk of arrhythmia. This was a study that was published in the American College of Cardiology. It was published in about atrial fibrillation mainly. This atrial arrhythmia is very common in obese patients. For patients that does not have atrial fibrillation, but have obesity, and when we do bariatric surgery for primary prevention, we can see that we have 29% less risk to develop first-time atrial fibrillation episode over 19 years. So it's a big improvement. While patients that already have atrial fibrillation and have obesity, and we treat them by bariatric surgery, we see that here there's no significant reduction in atrial fibrillation episodes, which is unusual as compared to the other risk factor. But we have 50% reduction in AF, atrial fibrillation related mortality. So there's no reduction in AFib episode, because AFib, when it's established, usually it's sometimes it's irreversible. It's due to scar tissue in the myocardium, and scar tissue, as you know, in the myocardium is usually an irreversible condition. So when we have it, even if we lose weight, even if we do bariatric surgery, most of patients will continue to have it, but the mortality related to this atrial fibrillation will be reduced by half. Now, when we talk about venous thromboembolism risk, there was a study that was published in the cardiovascular, in one of the cardiovascular journals. And in this study, they found no significant improvement of venous thromboembolism risk, even 2 years after surgery. So surgery did not influence the VTE risk occurrence. It was just statistically, we don't have any evidence of why reducing weight and reducing obesity did not lead to decrease in venous thromboembolism risk. This was just one study, so it's not in the guidelines. So it's just one study. So here you can see another example of a very obese patient of 102 kilograms. She had OSA, sleep apnea, and high blood pressure. And look at after treatment with bariatric surgery, she dropped her weight from 100 to 69. So a lot of weight reduction. So bariatric surgery remains the only sustainable weight loss tool we know. Because it can cure a lot of the diseases like hypertension, diabetes, cholesterol, and heart function, and reduce the risk of mortality. So even if it didn't cure these conditions, it will most often lead to improvement of these conditions and reduction in the usage of medications. So now, what is the diet recommended for hypertension and obesity-related obesity? So we know that the DASH diet, which was the DASH is dietary approaches to stop hypertension. It was first initially used to treat hypertension and obesity. So fruit and vegetables, whole grains, low-fat dairy, lean meats. So we need to reduce the red meat. Fish, we need to increase fish, and we need to decrease saturated fat, and we need to limit sodium, because we know sodium will cause increase in high blood pressure, and obesity as well will cause increase in blood pressure. So combining sodium to obesity will further increase the blood pressure. Now, for the grains, we need to have 5 to 6 daily serving. For example, fruits, 1 to 2. Vegetables, we need to have around 4 to 5 serving per day. Low-fat dairy products, 2 to 3 serving per day. Chicken, egg, fish, and meat, 1 to 2. Nuts, it's very important, nuts and seeds, 1 to 2. We need to reduce fats and reduce oils. We need to reduce sugar, so not more than 10 grams. A day. So benefits of potassium. Usually when we talk about diet, we rarely mention potassium, but potassium is very essential. And potassium helps in multiple body function, including the regulation of blood pressure, the water balance, the digestion, because if patients with hypokalemia, so low potassium level, sometimes they can develop ileus or intestinal obstruction from low motility. So potassium is very essential for gastric motility and intestinal motility. Heart rhythm is very related to potassium, because a variation of potassium can lead to significant arrhythmias, can lead to lethal arrhythmias. So we need to make sure our potassium is always in the normal range, which is between 3.5 milliequivalent to 5 milliequivalent. So this is very important, and it helps in the pH balance, so acidity and alkalinity. And usually our body doesn't produce potassium because as you know, potassium is usually stored inside our cells, so it's an intracellular component. Our body does not produce potassium regularly, so it's important to consume the right balance of potassium-rich foods. So we need to add this to our diet. So the diets that are rich in potassium are the cooked cereals, are the legumes and beans, are the low-fat milk, a lot of fruits like the bananas. The bananas contains around 10 mg of potassium. So if we eat, for example, a banana a day, we'll increase our potassium. If our potassium is 3.6, it will go up to 3.7 by just eating one banana. Vegetables, a lot of vegetables are rich in potassium. Nuts and seeds are rich in potassium, and some types of fish and garlic and herbs are also rich in potassium. But you need to make sure for patients with end-stage kidney disease and chronic kidney disease, especially patients on dialysis, we need to make sure not to increase a lot of their potassium, because increasing their potassium will cause a lot of side effects, like we said, we cause cardiac arrhythmias. So we need also to use diet with low sodium, so low fat milk, fruits like banana. So banana is rich in potassium, but it's low in sodium, so it's very effective to add it to the diet, to our daily diet. A lot of the vegetables, eggs, chicken, turkey are low in sodium, and nuts and seeds. So nuts and seeds as well, like bananas, they have high potassium and low sodium concentration. Homemade soups and low sodium salad. So we need to use lemon, tomato pulp, or vinegar as a substitute for salt. So we need to use things that have the same taste of salt and add it to the diet, but that have less sodium level. So these are the diets that contains high sodium. So you can see that a lot of diets that we eat every day, cheese, for example, is rich in sodium. Burgers, pizza, fries, and they are all rich in sodium. So we need to make sure to reduce these diets from our patients at risk. You can see here that the concentration of fat in the different oil we use. You can see that olive oil, for example, had 14 SFA percentage, and the butter and coconut oil have a higher value of saturated fatty acids. So we need to make sure of this. The butter contains also 6.6 grams per liter of cholesterol. So we need to make simple changes. For example, we need to add to use grain products. We need to add the good grains, and we need to avoid the bad grains, and we need to use our proteins wisely. So we need to use vegetables, low-fat dairy products, eggs, for example. But we need to avoid these proteins like full-fat dairy, like hot dogs, like red meat, like fried or breaded meats, like organ meats such as liver. And we need to increase, for example, olive oil, sunflower oil, safflower oil, and rice bran oil, and avocados, while we need to decrease butter oil because we said it is rich in cholesterol. We need to decrease cream sauce and other fats that's found in chocolates as well. So we need to make like a program for our patients, like how to what to eat every day, and we need to send our patient to dietary specialist in order to help the physician improve the quality of life of patient and improve his cardiovascular health. So these are the food that are rich in healthy fats. So avocados are very effective, almonds, walnuts, and you can see the list here. They are rich in omega-3 fatty acids and polyunsaturated fatty acids and monounsaturated fatty acids. So garlic also has multiple therapeutic effects. Orange, which is a source of potassium and for vitamin C. Tomatoes, which is contains natural pigment with antioxidants, so it will decrease the inflammation that is caused by obesity. Leafy greens, which is also a source of potassium, which helps in also in decrease in the blood clotting that is associated with obesity, because we said obesity is an inflammatory condition associated with higher platelet activation and higher atherosclerosis and higher vessel thrombosis. Green tea, as we said, is an antioxidant which will reduce inflammation and it will protect our heart, unlike the dark tea, which does not have any antioxidant effect. We will now we just have a few slides about the relation between obesity and hypertension. So as you know, when we increase our visceral fat, as we said in the first slides, we will have increased fat around organs, and we'll have increased fat around kidneys, which will cause compression of our kidneys, and this will lead to increase in intrarenal tissue pressures by renal sinuses and retroperitoneal and visceral fat. So fat will cause compression of our kidneys, so this will lead to increase in the pressure inside of the kidney. Increasing the pressure inside the kidney will decrease the blood flow reaching the kidneys. So the kidney will think that we're in state of low cardiac output, so it will activate the renin-angiotensin-aldosterone system. The renin-angiotensin-aldosterone system is a very well-known system that elevates the blood pressure. So this is a direct effect of fat on the kidneys by causing activation of the system and causing mineralocorticoid receptor activation, which will lead to higher blood pressure. Decreased blood flow to the kidney and increase in pressure inside the kidneys will cause also a systemic nervous system activation in order to try to compensate this decreased blood flow, in order to try to increase the blood flow to the kidney. So it will accelerate the heart rate, it will vasoconstrict the vessels in order to shift the blood from other organs to the kidney. So we'll have vasoconstriction, for example, around the stomach, around the lungs, in order to shift the blood pressure from different tissues to the kidney. And this will vasoconstriction, that will be a systemic vasoconstriction in the body, will lead to an elevated blood pressure. So it's a direct relation. We have a direct relation of obesity and hypertension. This was a kidney of a obese dog. So they did an autopsy of an obese dog after his death, and they found that his kidney was filled with fat. As you can see here, it contains fat. So this kidney for sure had a higher pressure inside of it and had decrease in blood flow. Here you can see also that there is fat cells also inside the renal sinuses. So not just on the outside, it's from the inside as well. This will also lead to increase in pressure in obese dogs. And we have the same physiology, so animals and the humans. So in humans, we think that it's of the same mechanism as well. Here is a biopsy of this obese dog kidney. As you can see, the image on the left is for a non-obese dog. You can see it has a normal morphology, while for the obese dog, you can see there is increase in fat concentration in the renal medulla, interstitial renal medulla. So we have increase in fat, so increase in comorbidities, increase in blood pressure as a result. So to resume, obesity will lead to renal compression. Renal compression will lead to activation of the renin-angiotensin-aldosterone system. As you know, the renin-angiotensin-aldosterone system will cause increase in sodium reabsorption, because aldosterone has an effect of increasing sodium by causing increased sodium reabsorption, and will lead to decrease in potassium concentration. So we gain sodium and we lose potassium by activating this system. So increase in sodium reabsorption will further increase our hypertension. So here is a CT scan performed on middle-aged and elderly individuals at risk of cardiovascular diseases. As you can see on the CT scan on the image below, we have increased in retroperitoneal fat. So kidney is a retroperitoneal organ, so we have fat around this kidney, which we can see clearly on the image. And we have renal sinus fat, so fat that is inside our kidney. So we have increased fat outside of our kidney and fat inside our kidney, which will lead to increase in pressure and lead to high blood pressure at the end. So here for patients that have had a high fat diet, and they have high blood pressure. So they tried to use a medication, which is eplerenone, which is a mineralocorticoid receptor antagonist. So it's called eplerenone. It's like Aldactone that we use in our hospitals, spironolactone. Eplerenone is from the same family, but causes less side effects like less gynecomastia in males. So they compared the two groups, a group that eat a high-fat diet without a medication, and a group that eats a high-fat diet, but they used with it a medication called eplerenone. The yellow figures here on this chart are for the medication group, and the white is for the control group. And you can see that the patients with this medication have a lot of reduction of sodium retention. So they oppose the mechanism of aldosterone, which used to retain sodium. Here we have medications that oppose aldosterone, so we have a decrease in retention of sodium, so we have decrease in blood pressure. Same for mean arterial pressure. You can see that the group in yellow is a group of the medication. We have a decrease in mean arterial pressure, which was significant as compared to the group that didn't use this medication. They even tried in this study to add another medication to the eplerenone, which is lisinopril. Lisinopril is an angiotensin converting enzyme inhibitor. So it works on the same system, renin-angiotensin aldosterone system, but it will work on an early stage of the system. So eplerenone will work on the aldosterone, which is the end stage of the system. Lisinopril will work on the initial phases of the system. And you can see when they combine the two drugs, so here between 7 to 14 days, they had the maximal mean arterial pressure reduction. It was a lot more than using no medication at all. It was also more than using just one medication. So combining these two medications in obese patients with hypertension was very effective. Same for alpha and beta adrenergic blockage, like alpha blockers and beta blockers. So because we said that in patients with obesity, we have activation of the sympathetic system. So the sympathetic system will work by secreting norepinephrine and epinephrine. And these transmitters will act on the alpha and beta receptors, which are found on multiple organs, including the heart, which contains the beta-1 receptors, and the blood vessels, which contain the alpha receptors. So when we use alpha and beta adrenergic blockage in these patients as compared to control, you can see that there's a significant reduction in mean arterial pressure. So the yellow curve is for the alpha and beta blockade, and it's lower than the white curve, which is for the control group, so no medication. And the mean arterial pressure was lower in this group. So here we have also another option to reduce blood pressure in obesity, which is called bilateral renal denervation. So it's an invasive procedure. When we do the denervation procedure, we can see that we have drop in arterial pressure in the denervation group, which is the yellow group, and we have decrease in sodium retention. So we have decrease in blood pressure after 5 weeks from this therapy. So to resume, visceral obesity will lead to increase in renin release, increase in angiotensin II release, and increase in aldosterone release. All of this will cause increase in renal sodium reabsorption. So when we increase renal sodium reabsorption, in addition to decreasing our parasympathetic activity and increasing our sympathetic activity, so stimulating the alpha receptors that are found in the vascular system, we increase the heart rate and we increase the renal sodium reabsorption. So both increasing renal sodium and increasing heart rate will increase our extracellular volume, because increasing sodium will attract water. So it will increase the volume and it will increase arterial pressure on the long term. So it's very important to use medications, like we said, like angiotensin converting enzyme inhibitor like lisinopril, and mineralocorticoid receptor antagonist like spironolactone or eplerenone. We need to treat dyslipidemia. We need to treat the metabolic syndrome associated with obesity. We need to treat insulin resistance. We need to treat an inflammatory state. We need to treat the renal injury. So we need to also implement a reduction in our calories intake and increase in our physical activity in order to fight this this disease, which is now considered a global pandemic. Thank you. I'm done with this slide. If you have questions, I'm ready to answer. Okay, so I have one question in the comments from Rawan. Which from bariatric surgery is more safe? So usually from the bariatric surgery, the sleeve gastrectomy is usually the safest option, because the Roux on Y, the second one, which was more effective, but it has a lot of risk, because you will have we'll have more anastomosis inside our GI system, so we'll increase the risk of leakage, the risk of infections. So sleeve is a bit safer, but sleeve has less effectiveness as compared to the other method. Any other questions? Dr.
Okay.
Eli will have a 5 minutes break and we'll continue with.
I think, yeah, I'm ready to start.
Okay,
because
great,
it's
great.
already 5 past 9.
Okay, perfect.
So it's better to, yeah.
Okay,
Thank you, Dr.
Okay, I will stop my screen sharing and.
Yes,
okay.
Thank you.
Okay.
Hello, everyone. Are you hearing me well? Yes, thank you. Okay. This session will be on the practice of cardiac rehabilitation. So to start with the cardiovascular rehabilitation, as you know, cardiac rehabilitation, we already talked about this topic, but as a quick reminder, it's a kind of program. So the cardiac rehabilitation, it's a kind of program, and it's designed to help patient improve health and recover from a heart attack, other forms of heart disease, or surgery to treat heart disease. So cardiac rehabilitation often involves exercise training, emotional support, educational about lifestyle change to reduce heart disease risk, such as eating a healthy diet, maintaining a healthy weight, and quitting smoking. So what are the cardiovascular rehabilitation goals? The goals of cardiac rehabilitation include establishing a plan to help patients regain strength, prevent condition from worsening, reduce risk of future heart problem, and improve health and quality of life. So research has found that cardiac rehabilitation programs can reduce risk of death from heart disease and reduce risk of future heart problems. So cardiac rehabilitation has evolved over the past decades from a simple monitoring for the safe return to physical activity to a multidisciplinary approach that focus on patient education, individually doing exercise training, modification of the risk factor, and the overall well-being of the cardiac patient. It has been also proven to be an effective tool for the care of the patient with heart disease. There is some recent research in cardiac rehabilitation has demonstrated that tremendous benefits can be derived, including derived actually from the optimal use of cardiac rehabilitation with various cardiac pathology like ischemic heart disease, heart failure, and post-heart surgery. Here there is this figure illustrates a model to show how the psychosocial and educational health behavioral component of cardiac rehabilitation has a central role, and that is linked with the successful management or change of each of the other components. Also aim to represent a patient-centered approach, if you can see here, again reflecting the WHO definition. So in this schematic, the patient psychosocial status and mental well-being, as well as his or readiness and ability to make health behavior change. So we have the long-term management, the risk management, treatment, and implementation of devices, smoking cessation, physical activity, diet, and all of this will be centered to the weight management and education behavior change. Okay. The sound is good now. Someone is saying the sound is not good. Okay, thank you. So why it's done? The cardiac rehabilitation is an option for people with many forms of heart disease, as we said, like heart attack, coronary artery diseases, heart failure, peripheral artery diseases, chest pain, cardiomyopathy, certain congenital heart disease, and coronary artery bypass surgery, angioplasty and stents, heart or lung transplant, and heart valve repair or replacement, pulmonary hypertension. What are the benefits of cardiac rehabilitation? So cardiac rehabilitation can have many health benefits in both the short and long term, including, as you can see here, strengthening the heart and body after a heart attack, relieving the symptoms of heart problem, such as chest pain, building healthier habits, such as getting more physical activity, quitting smoking, eating a healthy diet. So here it's good to see a nutritionist or dietitian. It may work to help patients limit food with unhealthy fats and eat more fruits and vegetables that are high in vitamins, mineral, and fiber. As you can see, it's a multidisciplinary approach. So we have it's better for the patient to see a multidisciplinary team. Reducing stress and also improving the mood of the patient. So people are more likely to feel depressed after a heart attack. So cardiac rehabilitation can help also prevent or to prevent this this depression. Increasing energy and strength to make daily activities like carrying something, clipping, or going up the stairs, etc. Making more likely to take prescribed medicines that help lower risk for future heart problems. And the last point, preventing future illness and death from heart disease. So studies have found here that cardiac rehabilitation decreases the chance of dying in the 5 years following a heart attack or bypass surgery by about 35%. Okay. So what are the benefits of cardiac rehabilitation? Individuals who attend 36 sessions have a 47% lower risk of death. Why 36 sessions? Usually it's around 3 months of rehabilitation. 12 sessions per month, 3 sessions per week. So as a total, 36 sessions in 3 months. So have a 47% lower risk of death and a 31% lower risk of heart attack than those who attend only 1 session. So health systems can save also money if we follow a good rehabilitation program. Cardiac rehab participation also reduces hospital readmissions, and cardiac rehabilitation can have also many health benefits in both the short and long term, as we said before. What are the indications for cardiac rehabilitation? Indications are not restricted to post-acute myocardial infarction patient, for example. It's also cardiac surgery and coronary intervention, cardiac rehabilitation program here with for the cardiac surgery and coronary intervention. So the cardiac rehabilitation programs combined with technical advances have increased the number of patients returning to work. For example, symptomatic angina in patients who cannot be operated or revascularized percutaneously, cardiac rehabilitation together with optimal medical therapy will increase anginal threshold. So cardiac surgery for valvular disease also, for example, for valvular disease or congenital heart disease after careful evaluation. Also, it's indicated for heart transplant and heart failure patients are also potential, as I said, potential candidates for rehabilitation. So subject at high cardiovascular risk, namely hypertensive patient and or diabetics, can complete cardiac rehabilitation that will supervise physical training and establish primary prevention. What are the contraindications for cardiac rehabilitation? So there is the cardiac and others. So as we can see here, unstable angina, active pericarditis, high blood pressure, left ventricular outflow tract obstruction, grade 2 and 3 AV block, myocarditis, aortic dissection, acute thrombophlebitis, pulmonary or systemic embolism, severe psychological disorders, and severe mobility limitation. So a better understanding here of the result and potential risks of physical training has increased the indication of cardiac rehabilitation and limited contraindication. There are absolute contraindications to cardiac rehabilitation. They include all scenarios where physical exercises has a potential risk, such as angina or unstable angina or severe hypertension, aortic aneurysm, and maybe dissection or recent pulmonary problem, severe aortic problem, stenosis or problem, and documented inappropriate response of blood pressure to exercise together with symptoms suggesting severe left ventricle dysfunction. So this is the contraindication in general. Let's have an overview of the risks and complications also for the cardiac rehabilitation. So the risks and complication here, especially the ventricular fibrillation, myocardial infarction, and sudden death. So the most feared complication of cardiac rehabilitation are ventricular fibrillation and myocardial infarction and sudden death. They would likely occur during or after exercise. There is a potential risk for complications increases significantly when 80% almost of maximal aerobic functional capacity or 85 of maximal heart rate is exceeded. So here surveillance is recommended during resting periods and 15 minutes after physical training. accident during cardiac rehabilitation. Some accident could occur, like angina pectoris. Okay, here I have just put like moderate accident and severe accident, just to make the difference between the moderate and severe. So moderate angina pectoris, like hypertension, vasovagal syncope, dyspnea, papillary muscle function, electrocardiographical, ST segment elevation and depression, supraventricular ectopic beats and ventricular ectopic beats, and atrioventricular block. As for the severe accident, intracranial hemorrhage, acute myocardial infarction, ventricular fibrillation, tachycardia, and death. Okay. During cardiac rehabilitation, the first stage of most cardiac rehabilitation program generally lasts about 3 months, as I said before, but some people will follow the program longer. So some people might be able to do an intensive program for several hours a day that can last 1 or 2 weeks. During cardiac rehabilitation, likely work with a team of healthcare professional, possibility including cardiologists also, it's better, nurse educators, nutrition specialists, exercise specialists, mental health specialists, and physical and occupational therapists. As I said, it's a multidisciplinary approach and team. Here, so here we have 4 stages of cardiac rehabilitation. We have the phase 1, it's in-hospital patient period. The phase 2, it's post-discharge pre-exercise period. The phase 3, exercise and education program. And the last one, the phase 4, it's the maintenance. So the phase 1, the acute phase or in-hospital patient period, so it's the initial phase of cardiac rehabilitation after a cardiac event. So it's an acute care physical therapist will work closely with healthcare providers, nurses, and other rehabilitation professionals to help the patient start to regain mobility in this stage. If it's a severe cardiac injury or surgery, such as, for example, open heart surgery, the physical therapist may start working in the intensive care unit. Once the patient is no longer required to the intensive monitoring and care of the ICU, he may be moved to a cardiac step-down unit. During the phase 2, it's the post-discharge pre-exercises period, as I said. So once the patient leaves the hospital, cardiac rehabilitation program will continue at an outpatient facility. So phase 2 of cardiac rehabilitation usually lasts from 3 to 6 weeks and involves monitoring or continued monitoring of patient cardiac responses to exercise and activity. Here there is another important aspect in this phase, the education about proper exercise procedure and about how the patient can self-monitor heart rate and exertion level during exercise. So this phase centers around patient safety or patient safe return to functional mobility while monitoring the patient, especially monitoring the heart rate. Toward the end of phase 2, patient should be ready to begin more independent exercise and activity. Moving to the phase 3, the intensive outpatient therapy or exercise and education program. So it's a more independent and a group exercise. So patient should be able to monitor his own heart rate, his symptomatic response to exercise, and his rating of perceived exertion. So here the therapist or the physical therapist will be present during this phase to help patient increase his exercise tolerance and to monitor any negative changes that they might occur during this phase of cardiac rehab. So here the patient become more independent. So during this phase, here the physical therapist can help tailor a program of exercises. So can give the patient a program of exercises, including flexibility, strengthening, and aerobic exercises. We will see in further slides some more details about this. The last phase, the phase 4, it's independent ongoing conditioning or maintenance. So in this phase, patient own independent and ongoing conditions. So he's independent so far, and he has like some ongoing conditions. So if he has participated fully in the previous 3 phases, so if he completed the 3 phases, then he should have excellent knowledge about his condition, the risk factors, and strategies to maintain his health. Independent exercise and conditioning are essential to maintain optimal health and preventing possible future cardiac problem. For the phase 4, it's, as we said, it's an independent maintenance phase. So independent maintenance routine should be present to help patient achieve physical fitness and wellness. So this is the phase 1. So as we said, it's acute phase in hospital patient period. We have the assessment, education, physical therapy, and the discharge plan. So as per the assessment, cardiac rehab team may run the following tests: heart rate, blood pressure, oxygen saturation, upper extremity function, including strength and range of motion, lower extremity strength, functional mobility such as walking and self-care tasks. And they will also take a full medical history to identify any particular risk areas or comorbidities, like other diseases that might complicate recovery. So we should know about everything. The education, so it's the phase to receive education and training on, it's the cardiac event itself, specific aspect of your diagnosis and condition, managing psychological reaction to the event, managing cardiac pain or other symptoms, monitoring the patient, and here the patient will be closely monitored to make sure that he don't experience any worsening of symptoms or risk another cardiac event. Physical therapy, as you know, patient may be assigned an acute care physical therapist who will design a carefully monitored, progressive, and very limited exercise program to get patient back on his feet again. This might involve initially just sitting up in bed, through standing and testing range of motion before moving to short walks around the hospital wing. So it's a little bit limited and moderate. Discharge plan, cardiac rehab team will also be able to plan for leaving the hospital. They will access ability to walk, need for home oxygen, for example, and assess any additional training or medical needs patient may have before he leaves. They may also work with patient family or loved ones to ensure have adequate care and support when discharged. What are the goals for phase 1? The main goal for the first phase of cardiac rehabilitation is to enable patient to leave the hospital and return home as quickly and safely as possible. And patient will work with doctors, nurses, physical therapists, or other specialists to design a safe and appropriate discharge plan. By the end of this phase, patient should have a safe, limited exercise plan that he can follow at home, a clear understanding of his condition and his cardiac rehabilitation program, and knowledge about self-care for his wounds, if open heart surgery, for example, an assistive device such as a can or walker if needed, access to home oxygen therapy if needed also. And by the end of this phase, patient should have recovered sufficiently to return home and begin the second phase of cardiac rehab. Okay, so moving to the phase 2, subacute outpatient care, so post-discharge, pre-exercise period. So this phase 2 takes place after patient leaves the hospital at an outpatient care facility. The second phase will last between 3 and 6 weeks. The primary focus of this phase is close monitoring to ensure that patient is progressing in recovery. And he will also receive more extensive training on how to manage his condition. The cardiac rehab team will review how heart responds to gradually increasing level of exercises and activity. So we do the monitoring patient. The patient will receive guidance on how to use medication and how to reduce the risk of cardiac events. During this stage, the aim is to reach a point at which patient will be able to exercise and begin journey to full recovery. What are the goals for phase 2? Reinforce learning from phase 1 and move towards independent self-care. So reinforce learning from phase 1. It's the main goal for phase 2 and is to support learning from phase 1 and ensure that patients have taken all the new information on board. He will monitor it. He will monitor as he makes any necessary lifestyle changes and begin to progress with exercises regime. The move towards independent self-care, it's the other key aspect of the second phase of cardiac rehab, is to help patients become more independent and informed. He should learn how to self-monitor heart rate and exertion level during exercise. The main goal is to increase levels of independence and to enable to move into phase 3. So we're gonna prepare the patient to move forward to the phase 3. So phase 3, it's intensive outpatient rehab. So if a team of cardiac rehab specialists here, including doctors, nurse, physiotherapists, and nutritionists, will put together an individual treatment plan customized to current physical condition. So the rehab program at this stage will involve close assessment and monitoring and exercise and further training. So if a patient experienced a severe cardiac event or surgery, he will probably need to complete phase 1 and 2 before moving, as we said. And some patients with less intense cardiac conditions may enter phase 3 directly without passing through the phase 1 and phase 2. So the phase 3 introduces more independent exercises and self-monitoring. So in this phase, we have the exercises, we have education, we have also the stress management, etc. So starting with the exercises, during the cardiac rehab, exercise program will be closely supervised by medical professionals to ensure patient safety. So physical therapist will evaluate patient before beginning, taking careful note of range of motion, first of all, muscle strength, resting heart rate, blood pressure, also respiration, endurance levels, and any issues with scar mobility, if any surgery. So it's a global assessment. So cardiac rehab exercise session will usually include a warm-up, a cardiovascular exercises, and a cool down. So cardiovascular exercises like such as the use of stationary bike or treadmill, something like that. Depending on physical condition, patient may also be advised to include some resistance training. He will be encouraged to monitor his own response to exercise, including heart rate, level of exertion, and blood pressure. Moving to the education, in the education we have the nutrition, lifestyle, and stress management. Starting with the nutrition, it's eating a heart-healthy diet is critically important for patients with cardiovascular condition. We had this. You had the session with yesterday with Dr. Anthony. It was very good, and so here the patient also need to aim to maintain a healthy weight to avoid putting undue strain on heart. He will be provided with a diet plan by cardiac rehab team. Generally, a diet that promotes heart health will be low in salt, as we said yesterday, low in sugar and in trans fats, and include fruits, vegetables, whole grains, and lean protein. Moving to the lifestyle, it's a long-term quality of life with a heart condition may require patient to make changes to his lifestyle, for instance, by quitting smoking and exercising regularly. During the phase 3 of this cardiac rehabilitation program, team of rehab specialists will help support to make any necessary changes and provide patient with guidance and advice on how to make this change permanent. So talking about the stress management, it's a very important so to learn how the patient can manage stress well. So cardiac rehab program here may well include stress management training, such as breathing techniques and meditation to help keep stress levels down once rehab finishes. And the patient may also receive counseling to help address any underlying factors that could be creating anxiety. What are the goals of for phase 3? The main goal for phase 3 of cardiac rehab is to give patient the tools to manage heart conditions on his own and live a longer, happier, and healthier life. So when a rehab program is completed, patient should have a clear idea of how to manage symptoms, how to deal with chest pain, how to keep an eye on blood pressure and exertion level, and control own medications, control the oxygen, and other treatment. Patients should also have a good understanding of the elements of heart-healthy lifestyle, including how to exercise safely, how to eat well, and how to manage stress levels. He will have also successfully stopped smoking, hopefully, and make any necessary lifestyle change to promote overall well-being. Also, he can experiencing fewer symptoms from heart conditions and be less likely to have a second event or need to return to the hospital. That's why the education of the patient is very important. Moving to the final phase, the phase 4, it's maintenance, essentially continues for the rest of patient life. During phase 4, patient should continue to follow the guidance on exercise, nutrition, lifestyle as set out by the rehab team. So patient may proceed independently or may decide to self-fund further training with a physical therapist to help support progress, There are also qualified gym instructors, for example, who can offer ongoing exercise training. But here, patients should receive regular checkups with healthcare providers to make sure that he is effectively managing his heart condition and avoid any flare-ups or problems. The goals of phase 4. The goal of phase 4 is to continue to maintain the changes to lifestyle that instigated in phase 3. Patients should keep up with exercise regime, continue to avoid tobacco, eat well, and manage stress. Moving to the assessment and outcome measures, it's essential to set and evaluate the effectiveness of an exercise program, provide objective feedback to the patient, and facilitate evidence-based practice. So assessing the fitness level for an exercise program, it's like assessing and recording baseline, like starting fitness scores, can give benchmark just to do the comparison after. So it can give the benchmark against which to measure patient progress. So it's valuable to assess patient progress on a regular basis. For example, each month we can do this evaluation. Remembering progression with some goals may be achieved in shorter or longer period of time. So before starting a new exercise program, patients should record pulse rate before and after a walk, for example. How long it takes to walk a certain distance. So patients should record this before starting the exercise. So how many bench, like push-ups or squat, can do in 30 seconds? Waist circumference measured midway between the top of hip and the bottom of ribs. The body mass index. Patients should always consult a physiotherapist or health professional to help him interpret this information, or to do a fitness assessment and work out with what sort of program is best for him. As there is some assessment and outcome measures, the 6-minute walk test is a sub-maximal exercise test used to assess aerobics capacity and endurance. The distance covered over a time of 6 minutes is used as the outcome by which to compare changes in performance capacity. So this test can be used in preschool children and children, adults, elderly adults, 65 plus, with a wide range of diagnoses including. The test was initially designed to help in the assessment of patients with cardiopulmonary issue. Gradually, it was introduced in other conditions. It evaluates the functional capacity of the individual, and it provides valuable information regarding all the systems during physical activity, including pulmonary, cardiovascular system, blood circulation, neuromuscular units, body metabolism, and peripheral circulation. Some condition of where the 6-minute walk test can be used or listed before. So we have the geriatrics, multiple sclerosis, for example, Parkinson's disease, spinal cord injury, stroke, etc. Equipment required for the 6-minute walk test: stopwatch, measuring trundle, wheel to measure distance covered, 30-meter stretch of unimpeded walkway, 2 cones of mark the distance that needs to be covered. Pulse oximeter for measuring heart rate. It's optional. It's not So the object of this test is to walk as far as possible for 6 minutes. Assessment and outcome measures of shuttle walk test. So it's another walking test. So this is a standardized field test for the assessment of endurance capacity in patients with chronic lung disease and cardiovascular disease. The patient is required to walk around 2 cones set 9 meters apart. So the final track is 10 meters in time to a set of auditory beeps played on an application. So the shuttle walk test, initially the walking speed is very slow, but each minute the required walking speed progressively increases. So the patient walks for as long as they can until they are either too breathless or can no longer keep up with the beeps, at which time the test ends. So the number of shuttles is recorded. Each shuttle represents a distance of 10 meters. Each time the patient reaches a cone is 1 shuttle. So between the first cone and the second is 1 shuttle. The result of the shuttle walk test can be used to prescribe the intensity of walking training. Okay, now let's talk about the outpatient rehab. So we have 4 mainly heart healthy exercises: the walking, yoga, cycling, and strength training. The walking, regular walking, can reduce the risk of heart attack, lower the LDL, the bad cholesterol, and raise the good one, the HDL, lower blood pressure, helps manage weight, and improves the mood. As per the yoga, practicing yoga may help lower blood pressure, blood cholesterol, and blood glucose level, as well as heart rate, making it a useful lifestyle intervention. As per the cycling, regular cycling stimulates and improves your heart, lungs, and circulation, reducing risk of cardiovascular diseases. Cycling strengthens the heart muscles, lower resting pulse, and reduce blood fat levels. We will talk independently, and we're going to talk about the walk, the cycling, the yoga, etc. Strength training increases lean muscle mass, and it gives cardiovascular system places to send the blood being pumped. This result is less pressure on arteries, which helps reduce the chances of heart-related problems. The monitoring is very important, so we should keep tracking of the following measurement during exercise session: target heart rate, rating of perceived exertion, blood pressure, angina, and shortness of breath, recording measurement. Always we have to monitor the patient. Starting with the walking and the treadmill. Why is walking good for cardiovascular patients? Walking is a type of aerobic exercise like cycling or swimming, which promotes the pumping effect of the heart and helps it to work more efficiently. The great thing about this is that just about anyone can do it. We can do it anywhere, anytime, and on our own. So patient can do it at his own speed. When to start walking? After a cardiac event, patient may begin walking straight away. So it's important to start with a small amount and build up gradually. So if possible, start with a short walk, 5 to 10 minutes, somewhere flat to begin with and close to home. So a short loop would be good for the patient. So the patient may find also reassurance in taking a friend or family member with him for the first few walks. How often can patient walk? Patient should aim to be active most days of the week. If he feels like he cannot manage to be active most days of the week, patient may wish to start with just 1 to 2 walk per day, and then gradually progress over the week to do a little more each time. Alternatively, he might find it appropriate to begin walking every day. So it's up to him to determine how much to do. But generally, the more regularly he can, it's better. How long should the patient walk for? Inside or outside? So patient should include a warm-up and cool down as part of his work. It's very important to start with a warm-up and to finish with a cool down. So this warm-up should aim to be around 10 to 15 minutes in duration. The aim of the warm-up is to gradually raise heart rate and increasing the blood supply to the relevant muscles. Patient should start slowly and gradually increase the size and speed of movement. The duration of the conditioning phase will vary depending on patient himself. So when starting a new activity, patient should begin with a duration that he feels he will be comfortable with. So maybe like 5 to 10 minutes for some. So he can then begin to increase the duration over time, working towards a total walking duration of 30 minutes at the end. So walking exercise should be finished with a cool down period of 10 to 15 minutes, gradually lowering the intensity of walking to help heart rate return to a resting level. So it's very important not to just stop exercising suddenly, as this may lead to a dizzy or light-headed feeling. So a slow and steady reduction in the intensity is ideal. What intensity should the patient walk at? So when participating in any activity, it's important that the patient should be able to rate how demanding or strenuous that particular activity is for him. If his muscles are aching and feel very heavy, he's likely to be working at a hard intensity and should ease off slightly. If he finds that breathing becomes uncomfortable, and he's probably overexerting himself and should slow down. Let's move to cycling. Is cycling good for cardiovascular disease? So what are the specific benefits of cycling? Patient may feel a more comfortable exercise as its low impact on the joints. Cycling can be suitable for all levels of fitness, from beginner to intermediate and onto advanced. What cycling can help to improve or maintain? We have the aerobic fitness, strength, especially in the lower body, psychological well-being, joint flexibility, in particular improve the range of movement in the knees, hips, and ankles. When to start? It depends on patient current level of physical fitness, as well as cardiovascular condition and general health. So people who have had a heart attack and or a stent fitted may be able to start quite soon. So once assessed by a cardiovascular exercise professional. People who have had heart surgery may be able to use a static bike immediately after surgery, but to minimize problems, which like breastbone healing patient may be advised to wait before using a bike on the road. People who have a permanent pacemaker or implantable cardioverter device should wait for 6 weeks after the device has been fit, and they may be able to use a static exercise bike, and the cardiovascular exercise professional will advise when to start. How to get in shape? Cycling can be adapted for most level of fitness. It may be useful to attend cardiovascular rehab. They can use the static bike if available before going out on the road. As you know, there are also seated pedals available for people who need to work out in the chair. who cannot move or cannot walk or cannot ride a bike. So may feel a more comfortable exercise as it is low impact. So patient should stop exercising if he experiences any chest discomfort, palpitations, dizziness, or lightheaded. If the symptoms do not go away promptly with rest, patient should seek medical advice as soon as possible. How should patient feel during the session? Patient should listen to his body and think about how it compares with how he feels in his cardiovascular rehabilitation exercise session. So working comfortably at moderate intensity is recommended. High intensity exertion or sprint training should be avoided as this may cause problem of some people. Let's talk about warm up and cool down. So what about warm up and cool down? So warm up the first 15 minutes at the and last 10 minutes of the session should be performed at a lower intensity. So patient should use gears or resistance settings and try to avoid steep hills. So warm up minimum is 15 minutes should feel light intensity. The aerobic workout, it's aimed to build up to at least 20 minutes. The cool down minimum at 10 minutes, slow down and go don't go quickly. Legs are going until feels recovery. If patient fitness allows him to do a shorter session, then patient should try to start slower for 5 minutes and finish slower for 5 minutes. Other things to consider, it's a general things to consider. Wear a helmet when cycling outside. Try to avoid cycling in highly polluted areas. Adjust the seat. Cycling doesn't do much to strengthen the upper body. So patient should find exercises to work the upper body. Patient also should plan a route in advance. Consider if he can warm up and cool down, for example. Don't exercise immediately after eating a large meal. Patient should remember to always have a bottle of water and not to exercise if he feels unwell. Moving to the yoga. So according to Hav Kalkens, MD Director of the Cardiac Arrhythmia Service at Johns Hopkins, a large number of studies show that yoga benefits many aspects of cardiovascular health. Beyond offloading stress, practicing yoga may help lower blood pressure, blood cholesterol, blood glucose levels, and heart rate. Yoga heart connection. So exercise that revs up your heart rate isn't the only kind of physical activity that can help prevent or manage heart disease. So yoga as a stress outlet, for example, so one of yoga's clearest benefits to the heart is its ability to relax the body and mind. And emotional stress can cause a cascade of physical effects, including the release of hormones like cortisol and adrenaline, which narrow arteries and increase blood pressure. So the deep breathing and mental focus of yoga can offset this stress. Yoga as heart booster. So beyond offloading stress, practicing yoga may help lower blood pressure, blood cholesterol, and blood glucose level, as well as heart rate, making it a useful lifestyle intervention. So one study has shown that blood measurement and waist circumference, a marker here of heart disease for sure, improved in middle-aged adults with metabolic syndrome who practiced yoga for 3 months. There is also another study that shown that slow-paced yoga classes twice a week reduce the frequency of arterial fibrillation episodes in patients with that condition. Moving to the yoga as smoking cessation aid, some research indicates yoga might be a useful tool in helping quitting, or smoking is one of the biggest risks, as we know, the risk factors of heart disease. Yoga as exercise. Yoga can also improve flexibility, muscle strength, and balance because it's not a form of aerobic exercise that raises the heart rate. However, patient shouldn't count the time he spent doing the yoga as part of recommended weekly total for moderate to vigorous physical activity. Strength training. In strength training, we have the aerobic exercise, the resistance training, and the stretching, flexibility, and balance. Aerobic exercise. What is the aerobic exercise? So it's a cardiovascular exercise or cardio that gets heart pumping during aerobic exercise. Blood pumps quickly throughout the body and the lungs take in more oxygen. So the word aerobic means with oxygen, meaning that breathing determines the amount of oxygen that gets to the muscle. Benefits of aerobic exercises. Many health experts agree that aerobic exercise is the most important part of any fitness routine. So anybody can benefit from this kind of exercise, and the more cardio the person do, the more the body will adapt. Resistance training. So talking about the resistance training with weight. So with weight or with elastic bands or on your own body weight, for example, may help regain the physical strength and confidence to do the daily tasks that performed before the heart problem or surgery. So resistance training can help patients get the most benefits from the cardiac rehabilitation program. Stretching, flexibility, and balance enables subject to stay flexible and free from joint pain, cramping, and other muscular issues. So that flexibility is a critical part of being able to maintain aerobic exercise and resistance training. So if a patient have a good musculoskeletal foundation that enables him to do the exercise that help the heart. So flexibility and balance exercise help maintain stability and prevent falls also, which can cause for sure injuries that limit other kinds of exercise. So let's move to the torso stretch. So it's good to do some stretching, as we said. So flexibility is really very important. So I will show you some torso stretch, torso twist, etc. So torso stretch here, it says stretch the midsection waist. Starting position, it's sit tall with your feet flat on the floor, shoulder width apart. The action is to place the hands behind the head, as shown here, with elbows out to the side. So you can also cross your arms over your body. And it could be repeated 6 to 8 times on each side. You have the torso twist. It's to place hands behind the head with the elbow out to the side, and you can also cross the arm over the body or leave them at sides, whichever is most comfortable. Seated march. This is good for the phase 1 in the cardiac rehabilitation program. So increase hip flexibility. Starting position, it's sit tall with your feet flat on the floor, shoulder width apart. Action, raise one knee as high as you comfortably can. Return to starting position, repeat on the other side. So march 12 to 16 times. Rest, then do a second set. The quadriceps stretch, you know the quadriceps stretch. Hamstring stretch also, it's good. Calf stretch. There is some point to note during exercises. The score, a higher score means here more effective. So we have the sports and how the sports is effective on the cardiorespiratory endurance or muscular strength or flexibility or body composition. So the aerobics is really effective on cardiorespiratory endurance. It's less effective on muscle strength and muscle endurance. It's very effective on flexibility and very effective on body composition. The squash, same. Swimming is effective, very effective on cardiorespiratory, muscular strength, flexibility, and body is the swimming is less effective on flexibility and body composition. Table tennis, it's less effective on for the cardiovascular, respiratory, muscular strength and flexibility and body composition. So here just this pictures show us how we can do the warm-up. We should do the warm-up and then the main exercises and the cool down is very important, the steps of exercise. So safety guideline during exercise, replenish water as needed, wear sportswear and sport shoes, do warm up and stretching exercise every time before exercise, cool down after exercise, do not do strenuous exercise when feeling tired, build up intensity gradually. Safety also guidelines during exercise. If any of the following symptoms appear, the patient should stop exercise immediately. If there is pain in the chest or joint, shortness of breath or breathing difficulty, dizziness, stuffy stomach, feeling or nausea, palpitation or abnormal heartbeat, abnormal tiredness, and pain joints such as joints in knee or ankles. Okay. So I'm just have some question for you, like a quick quiz. If you can just participate with me. So to see how much you know about the cardiac rehabilitation. So cardiac rehabilitation, it's not only helps a person recover from a heart problem, but also helps prevent another heart problem in the future. True or false? Okay, so it's true for sure. Cardiac rehab is an important program for anyone recovering from heart attack, heart failure, or other heart failure. Cardiac rehab can aid in recovery as well as help prevent a subsequent event. It includes physical activity, education about healthy living, counseling to improve mental health. The second question is, who can go to cardiac rehabilitation? Older adults only, anyone who has had a heart problem, anyone who has had a recent heart attack, heart surgery, or a recent hospitalization for heart failure. Who can go to cardiac rehabilitation? 1, 2, or 3? 3, okay. C, 3. Najla, Wasim, Budur, Mohammed. Okay, Khalid, you said 2. Alia, 2. Mus'ad, all. Okay. Okay, let's see. So anyone who has had a recent heart attack, so it's the third choice, or recent hospitalization for heart failure. So cardiac rehabilitation is not for all heart problems. A person is eligible for cardiac rehabilitation if they can have had a recent heart attack, stable chest pain, angina, heart procedure, and heart surgery, heart valve repair or replacement, or a heart lung transplant. Some people with heart failure may also be eligible. How long do the third question is, how long do cardiac rehabilitation programs usually last? 7 days, 2 weeks, 3 months, 1 year? So 7 days, 2 weeks, 3 months, or 1 year. How long do cardiac rehabilitation programs usually last? Yep. Yeah, I said that before. Okay, thank you, Rawan, Manal, Fatima, Horia, thank you. Thank you so much. So yes, it's 3 months. So cardiac rehab program usually consists of 36 sessions over 3 months, but can range anywhere from 2 to 8 months. So we can extend the program, but usually it's around 36 sessions over 3 months. The first question is, what is a benefit of attending a cardiac rehabilitation program after experiencing a cardiac event? It reduces stress, it strengthens your heart and body, it builds heart healthy habits such as quitting smoking, all of the above. What is a benefit of attending a cardiac rehabilitation program after experiencing a cardiac event? 2. Okay, Alia said 2. Wasim, all of the above. All. Ali Hassan, 4. Okay, that means all. Okay. Thank you. So for sure, it's all. So cardiac rehab benefits your health in many short and long-term ways. It can also help relieve symptoms of heart problem, improve mood, increase energy and strength, and prevent future heart problem and premature death. The fifth question, cardiac rehabilitation program can only happen in a hospital. True or false? It's easy. Yes, it's false. Cardiac rehab program can happen in a hospital or rehabilitation center as well as in a patient's home. Thank you so much. That's the end of my presentation. Before starting the third presentation with Dr. Anthony, we will have like 10 to 15 minutes, maybe 15 minutes of break. It will be good for all of us. Thank you so much. Do you have any question before I quit?
You can see the slides, right?
Yes, yes.
Okay, perfect. So I will start. Our next topic is about physical assessment of patients. So we'll discuss here how to speak to patients, how to take the history from the patient, and how to do the physical assessment or the physical examination for our patients. So we need to first, when we see a patient, so we need to first start by discussing the personal history of the patient. So the name was very important for identification and to be familiar with the patient. So we need to ask him for his full name, because we can see a lot of patients having the same name and family name. So we need also to ask for the father's name in order to prevent in order to prevent malfunction with the health system. So we need to make sure to write the name correctly. We need to check for his age, because as you know, certain diseases and certain cardiac diseases are related to certain age groups. So for example, coronary artery disease are most of the time associated with older age, heart failure as well. But for example, congenital diseases can be found in young patients. So we need to check for age as well. Sex, because as we same for age, some diseases are more common in males, some others are more common in females. Nationality, it's also important, nationality and race, because nationality and race, for example, we see some patients with black skin or black race tend to smoke more than patients with white race. So it's also important. It's also important to note the home and the residence of the patient, his occupation, because some occupations we can have exposure to dusts, for example, or to pollutants, so it will increase our risk of to develop cardiac disease. Marital status and date of admission. After this, we need to check for the chief complaint. Why the patient is presenting to the hospital or to the clinic? We need to write it in patient's own words. So for example, if a patient mentioned shortness of breath, we need to write shortness of breath. We don't have to write dyspnea instead. So we need to write it as the patient said it. And we need to write the duration of the symptoms. So if the patient symptoms started 1 week, for example, if it's chest pains that started for 1 week, or chest pains that started since few hours. So when the patient says to us that the patient started 1 week, it's more reassuring, because if it's a myocardial infarction, usually it's a very acute presentation. So the patient will not stay at home for 1 week. And we need to sort the symptoms in chronologic manner. So we need, if the dyspnea started first, we write dyspnea first, then the chest pain, and 2 days later, for example. For example, we can have right inguinal swelling since 1 month. We can write it like this. Next, we move to past history. We need to ask the patient if he has a past medical history, like history of hypertension, diabetes, asthma, tuberculosis, hepatitis, HIV, and others. And when he was diagnosed. So if he had hypertension since 20 years, 10 years, 5 years, because the management and the cardiac complication would be different depending on the disease duration. And we need to ask him if he had similar conditions or similar symptoms in the past, if he had any chest pain similar to the chest pain he's presenting with this time. We need to ask him about previous hospital admissions, if he was hospitalized recently, if had any previous surgical intervention, or if he had a previous blood transfusion. We need also to mention family history. If we have family history of chronic diseases, because as you know, hypertension, diabetes, and asthma, for example, can be transmissible by family and from generation to another. If anyone from his family had similar condition or similar symptoms, if we need to check for inherited or genetic disease, because there's a lot of cardiac disease that are genetic. So we need to check for inherited diseases. Consanguinity. So if there's a marriage between two patients that are linked together, so from the same family or from the same area or same city, we can have consanguinity between them. If there is history of sudden cardiac deaths in the family, or if there is history of cancers. So moving to the social history is very important. We need to see where he lives, if his social and educational class, if he is an alcohol abuser, if he's a smoker, if he is a drug abuser, if he is sexually active or not, because alcohol, smoking, and drugs can be related to cardiovascular diseases, as you know. If we need to see if he has any history of recent traveling. We have the pulmonary embolism disease, which is very associated with traveling. For example, if someone travels in a plane or by train for more than 10 hours duration without moving, there's a lot that is a high risk of developing blood clots. So we need to ask a patient presenting, for example, for dyspnea or for atypical chest pain, if he has a recent history of travel, because we need to think of pulmonary embolism, which can also cause chest pain. So it's in the differential diagnosis of our chest pain. So not every chest pain is cardiac. We need to ask if there's a contact with animal. Last week, I saw a case of a patient. He was exposed to a dog, and he had a dog bite, and he presented with rabies, and he had a cardiac complication of rabies, which is very rare. He developed a rabies-associated myocarditis from his dog bite. So it's very important to always ask for contact with animals. Now, when we ask him if he smokes or not, so how to quantify smoking, to make it universal for all the files, the medical files, we need to do it in pack year. So we calculate the pack year, which is number of cigarettes smoked per day, times number of years he smoked, divided by 20. So we'll have a number. For example, we can have a number like 20 or 30 or 40. It's related, the number came from this formula. So we have to do for every patient this formula and write it on the file. Now moving to the general physical examination. So before going to the cardiac physical examination, we need to do the general physical examination. So the general physical examination, we need to check for appearance. So it's A, B, C, D, E. We need to check for appearance, if he looks well, if he looks ill, consciousness, So we need to ask him a few questions to see if he's conscious or not, if he's alert, if he's oriented to time. We need to ask him, do you know what, do you know the date? If he knows the time of the day, if he know where the place, if he has to tell us in which hospital and which country, if he knows the persons that are next to him. Then we need to move to B, which is body build. The body build, we need to check if the patient has average, is body build thin or obese, because as you know, obese will push us to think more of cardiac etiologies, for example, of a patient presenting for chest pain. If he's thin, we need to think of malnutrition or poor economic status, which are also associated with development of cardiovascular diseases. Moving to C, which is color, we need to check if he's pale, if he's cyanosed, if he's erythematous. For example, if he has heart failure, he can have peripheral cyanosis because less blood will reach the extremities, so we can have cyanosis. If he has vascular disease, we can have cyanosis. We need to check D, decubitus, which is the position of the patient. If he's sitting, if he's in standing position, so if he's in pain, he will not be able to sit in a fixed position. And E, which is the environment, we need to see any connection to patients, like if he has IV line, if he has a catheter, if he has O2 mask, so if he's an oxygen dependent at home, if he's on the wheelchair. So all of these are important in the risk stratifying of our patients. Now, after the general physical examination, we need to measure his vital signs. So we need to do this systematically for every patient that comes to us. So first of all, we need to measure the temperature. As you know, the normal temperature is 37.2 plus or minus 0.4 degrees Celsius. So temperatures of this range are considered normal. Pulse, usually some people say that pulse between 60 to 100 beats per minute is normal. Some said between 50 to 100. So we can say between 50 to 100 is acceptable pulse. Blood pressure, normally it should be less than between 120 to 139 systolic and 80 to 90 millimeter mercury diastolic. And now we are pushing to lower even this number to less than 130 systolic. So because above 130, we are now considering it an elevated blood pressure. Respiratory rate should be between 12 to 16 breaths per minute, and the oxygen saturation should always be above 98%. So for the blood pressure, when our patient presents with syncope, for example, so if he presents with loss of consciousness, we need to take his blood pressure while supine. So when he is supine on his back, then we need to ask him to stand for 2 minutes. And after 2 minutes, we need to recheck his blood pressure while standing. So if his blood pressure falls by 20 millimeter mercury systolic, this means that the patient has orthostatic hypotension. Orthostatic hypotension is a drop of blood pressure when the patient stands. So this will induce syncope, especially in old patient or in diabetic patients with autonomic dysfunction. So it's very easy for them to fall when they drop their blood pressure. And it's a very common cause of syncope. So most of syncope presenting to the emergency department are related to orthostatic hypotension. So we have to always ask the patient to stand up for 2 minutes, then remeasure his blood pressure standing and compare it to blood pressure when he's supine on his back. When the patient reports chest pain radiating to his back, so chest pain radiating to his back is an emergent condition. So we need to measure the blood pressure in both hands, because when we have chest pain radiating to the back, we need to suspect a rupture of the aorta, which is aortic dissection, which is a medical emergency. So it's if the first part of the aorta is affected, it's a surgical treatment. So we always have to suspect it when the patient tells us he has pain radiating to the back. So we diagnose it initially by measuring blood pressure in both hands. So now moving to the physical examination, we'll go system by system. So first we need to look at the patient hands, okay? So we need to see the nails. Nails are very important. They are nail abnormalities are related to multiple cardiac conditions. So when you see the pick number 1, this is called clubbing, digital clubbing. So when we see this, we need to suspect chronic hypoxia. So a condition that cause chronic decrease in oxygen pressure in the blood or oxygen saturation in the blood. So when we see this, we need to suspect hypoxemic conditions. For example, if a patient has AV fistula or if a patient has chronic hypoxia from sleep apnea or from Usually sleep apnea doesn't cause it a lot, but it can cause it. The pick number 2, you can see a medical practitioner. It's causing pressing on the nails, and this is called capillary refill. Normally, when you press, will cause whitening of the area, and after a few seconds, we should see it in its normal color. If the color stays white for more than expected, we need to suspect, for example, a low cardiac output or hypoperfusion to the extremities. Pick number 3, you see a very typical image. It's called splinter hemorrhage. We see this in endocarditis. So endocarditis is a bacterial infection of the heart valves. So when we can see this as a secondary sign of endocarditis. Peripheral cyanosis, as you can see in the picture number 4, it's associated with ischemic ischemia. So we can have narrowing of the arteries, with loss of blood supply to the extremities, we'll have cyanosis, and if left untreated, it can lead to gangrene or amputation of the digits. Pick number 4 is called koilonychia, which is this form of the nails. This form of the nails is usually associated with iron deficiency anemia. So when we see this, we need to ask the patient to do hemoglobin level to check if he's anemic. We need to dose his iron and his ferritin level and his transferrin saturation in order to diagnose iron deficiency anemia. Leukodystrophy in picture number 6, it's very common. A lot of us had this once in their lifetime. Usually it's benign and it's not associated with other diseases, but sometimes it's associated with a lot of congenital diseases and genetically transmitted diseases. Moving to the palm, we need to check the palms to check if we have muscle wasting. So if the patient is malnourished, we check if he's not eating, he'll have muscle wasting. If he has palmar erythema sometimes can be seen also in iron deficiency. Pallor, which seen in palmar creases, we need to check for pallor. Also, pallor also can indicate ischemia, can indicate dehydration. We need also to check for osseous nodes. You can see the picture on the bottom. We have osseous nodes and Janeway lesions. These are also signs of bacterial endocarditis. So bacterial endocarditis can manifest on nails and on digits and on the palm. So we always need to check for them, and we need to check for his eyes to check if he is pale or not. This can be due to anemia or to liver disease. Moving now to tremor, we check if the patient has tremor, if his hands are moving a lot. So tremor can be idiopathic without any other associated pathologies. It can be due to Parkinson's disease, for example. Parkinson's disease is a disease affecting all patients. It can also has cardiac manifestations. Moving now to the eyes, as you see, we need to check on like picture number 9. This patient had jaundice. So jaundice can be related to liver disease. It also can be related to heart disease, because when we have heart failure or right-sided heart failure, we'll have associated liver failure because the blood will back up around the liver. So we'll have associated liver failure. So the patient can present with jaundice. Pallor, as you see in picture number 10, as you said, it can be due to anemia, and periorbital edema, like picture number 11. This is attributed to most commonly thyroid disease, like hyperthyroidism and Graves' disease. It's a thyroid disease. And we can have xanthelasma in the picture on the right. You can see the blue arrow. It's like a pale discoloration above the eye, and when you see this, you need to suspect high cholesterol level. So we can have a lot of physical exam signs that will lead us to cardiovascular diseases and to diagnose cardiovascular diseases. Moving now to the mouse, so we also need to check for cyanosis. It's an indication of poor perfusion, poor cardiac output, jaundice as well due to liver disease, and we need to check for aphthous ulcer and candida, glossitis, and mouth hygiene and odor of Bess. This will also, you will see a lot of patients with bad mouth hygiene. Bad mouth hygiene can lead also to infection of heart valves. It lead to endocarditis because of bad mouth hygiene. So it's very important to check all these features for our patients. Moving now to the neck, you can see that in the neck, we need to examine the lymph nodes, the jugular veins, and the carotid arteries. Okay, after finishing with the neck, and we need to check the lower limbs. So now we're focusing on the cardiac physical exam, so cardiovascular physical exam. So on the lower limbs, we need to check for skin changing, muscle wasting, or loss of hair. We need also to check for edema. So when we suspect heart failure, most of patients with heart failure will present with extremity edema, so lower limbs edema, because the heart pump will fail to pump the blood, so they will accumulate in the venous system and they will cause venous lower limb edema. So when we press on the lower limb, we will check, we will have a pitting, and if we move our finger, we remark that it will stay like this. So this indicates an advanced heart failure, as opposed to non-pitting edema. Non-pitting edema is an edema when we press, and when we remove our finger, it will back to normal. So non-pitting edema is usually not cardiac related. It's related to other causes like lymphedema, so lymphatic edema, which is a different topic. We need also to check for it's unilateral edema or bilateral edema, because as you know, heart failure will cause bilateral edema. It will never cause unilateral lower limb edema, heart failure. So when you have unilateral edema, you need to suspect other causes other than cardiac causes, like for example, venous thrombosis by deep venous thrombus, DVT, or any other condition. We need also to check the pulse by putting two fingers to check the femoral, popliteal, and dorsalis pedis and the posterior tibial pulses. So all these pulses are located in the lower limb. So the cardiology ABCDE, we said that we need to check the appearance first, if he look well, if he's look ill, if he's conscious, if he's alert, if he's oriented to time, place, and person. We need to check if he's thin, if he's obese. We need to check if he's pale, if he's cyanosed. If we need to check if he's sitting or standing, or if he's, when he has pain. We need to check if he has any chest deformity, any congenital deformity, if he's breathing well, if he's dyspneic. So we need to check if he's on oxygen at home, if he's on wheelchair, because all of these are advanced features that will indicate a worsening of the prognosis. So temperature, as we said, it should be around 37. Some patients, some causes of fever in a cardiac patient. So when a cardiac patient comes with a fever, we need to suspect rheumatic fever. Rheumatic fever will affect the heart, will affect the valves. It's a disease related to a streptococcal infection, and will transform into a cardiac disease, a streptococcal bacterial infection. We can have acute myocardial infarction. Sometimes when you have myocardial infarction, we can have systemic inflammation associated with it. So we can have a fever and an elevation of inflammatory marker in the blood. Myocarditis, which is the inflammation of the pericardium, so the layer covering the heart, and the myocardium, inflammation of the myocardium, it can be due to viral illnesses, can be due to autoimmune diseases, and to other causes. It will cause fever. Acute pericarditis as well, which is the inflammation of the pericardial layer of the heart, the outer layer of the heart, it will cause fever. So not every fever is an infection. We can have fever related to any other inflammatory condition. Moving now to the respiratory rate. The respiratory rate normally range from 12 to 16 breaths per minute. Any respiratory rate above this target or below this target should be an alarming feature, because if a patient is very tachypneic, meaning a respiratory rate above 20, we might think of volume overload, pulmonary edema, which is not allowing him to breathe normally. Blood pressure, as we said in the previous presentations, blood pressure should be less than 130 systolic and less than 80 millimeter diastolic. The recent guidelines suggest these numbers. A blood pressure above 130 systolic is always considered elevated. And we should aim diastolic blood pressure in all age groups to be a diastolic less than 80 millimeter mercury. As we said, we need to check postural blood pressure. So we need to ask the patient to stand up and to measure his blood pressure standing. So blood pressure on standing position will help us diagnose postural hypotension or orthostatic hypotension. We can see this in hypovolemia, hypopituitarism, Addison disease, neuropathy, and drugs, cardiac drugs like vasodilators that we used in hypertension, diuretics, and antipsychotic and tricyclic antidepressants. So orthostatic hypotension is very common and it's very easy to diagnose. We just need to measure the blood pressure upon standing. So the systolic blood pressure normally can vary between arms up to 10 millimeter mercury. So for example, if we measure the blood pressure for a patient in the right arm, we have 130, and in the second arm, 120 systolic. This is normal. But if the difference of blood pressure between the two arms is, for example, above 20 millimeter mercury, in that case, we need to suspect of aortic disease like aortic dissection, because we will have impaired blood flow to one of the limbs, especially if the subclavian artery that is going to the upper limbs is affected. So, and usually the blood pressure in the lower limbs is higher than the arms. So up to 20 millimeter mercury, unless the patient have some degree of aortic coarctation, for example. So usually when you take the blood pressure in the lower limbs and you need the actual blood pressure of the patient is around 20 millimeter mercury lower, because the lower limb is higher than the upper limbs. So this is how we measure the pulse. We need to measure the radial pulse, the brachial pulse, the carotid pulse in figure C. We need to measure the abdominal pulses, the femoral pulse, and we need to measure the pulse in the lower limbs as well as the lower extremities. So we have the brachial artery pulse, the radial artery pulse, the carotid artery pulse, the femoral artery pulse, the popliteal artery pulse, the posterior tibial artery pulse, and the dorsalis pedis pulse. We need to measure all these pulse and check them for all our patients. So normally, as you said, it's between 60 to 100 beats a minute should be. So the bradycardia is less than 60, or some say less than 50. Tachycardia is more than 100 beats a minute. And if you want to count the rate by measuring when you measure the pulse, you can, for example, check how many beats you have in 15 seconds and multiply by 4. So you'll have the beats per minute. It's very easy to do, and we can do it for all our patients. So usually when you check the pulse, you need to see if it's regular or not. Normally the pulse should be regular. The duration from beat to beat should be equal. When you have irregular pulse, we need to suspect cardiac arrhythmias, and the most common cardiac arrhythmia we see in practice is atrial fibrillation. So we need to check for irregularity in the pulse. Sometimes you can have regularly irregular pulse. This is not atrial fibrillation. This is sinus arrhythmia. Sinus arrhythmia is very frequent in young patients. It's related to inspiration and expiration, to respiration. So when you have inspiration, you will increase you increase your venous return, so you will increase your cardiac output. So the heart rate during inspiration is a bit higher than the heart rate during expiration. That's why you can see some variation related to respiration. So we need also to check the volume of the pulse. If we have a very high pulse, so you put your hand on the pulse and you check if it's it goes up a lot, so it's a high volume pulse, you need to rule out hyperdynamic circulation. So patients have a high cardiac output related to anemia, for example, to pregnancy, to thyroid diseases, hyperthyroidism. All of this can cause a high volume pulse. A low volume pulse is seen, so when you see that the pulse is very weak. So if the pulse is very weak when you have hypovolemia, for example, or we have shock condition like septic shock, and if we have also severe aortic stenosis, so the heart will pump against closed aortic valve, so you will not be able to detect the pulse on the extremities. So sometimes we have something called radial delay. So we have a difference delay in the pulses between the right upper limb and the left upper limb. So when we have this, we also need to rule out aortic diseases. When we have radiofemoral delay, so you put your hand on the radial artery and on the femoral artery, so you can see a delay. The delay is also suggestive of aortic disease of coarctation of the aorta. Because coarctation, you will palpate the pulse in the radial artery in the upper limb before the femoral artery. You can have radiobrachial delay, so between the radial artery and the brachial artery. This is due to aortic stenosis. because the impulse will reach the brachial before the radial artery. Capillary refill, as we said, we need to press on the nail of the patient, and we need to, usually the pale color we induce should come back to normal in less than 2 seconds. If it stays more than 2 seconds, we need to rule out peripheral vessel disease, hypothermia, dehydration, and shock. This is a video. I will show you a video of the capillary refill. Are you okay? So we press on the on it, and it should come back to normal color in less than 2 seconds. So this is a normal case. Now moving to carotid examinations. So as you can see, I will put the video. So this is the carotid artery pulsation. Usually we should not see the carotid artery pulsation in our patient. When we see this carotid artery pulsation, we need to suspect a lot of condition like aortic regurgitation. So aortic regurgitation is a deficiency in the aortic valve. So instead of the blood going to the aorta, it will accumulate in the left ventricle, and the next beat you will have more blood going to the carotid arteries. So you will have increase in carotid pulsation as they become visible. Sometimes if your patient is very thin, you can see it, and it's normal condition. And you need to auscultate the carotid with the stethoscope to detect a murmur. And when you detect a murmur in the carotid, we need to suspect carotid stenosis, which is common in the elderly population and is associated with a lot of cardiovascular conditions. So we need to inspect the chest next. So we need to check for asymmetry in the chest to see if there is any bulge in the chest. When the patient have a pacemaker, you will see the device under the skin. So you see a bulge. A pericardial effusion sometimes can cause it, an atrial or ventricular enlargement. You can detect it to the outside sometimes if it's very big. You need to see if we have kyphosis, scoliosis, because these will cause restrictive lung disease, and restrictive lung disease will lead to cardiac disease as a result. Pectus excavatum, we see a picture later. Pectus carinotum is our chest wall deformities, as well as our congenital chest wall deformities. We need to check previous scar. Why need to check a previous scar? To see if the patient have previous cardiac surgery, because as you know, cardiac surgery, you will see a scar that will remain on the chest. So this will indicate that our patient is a cardiac patient. And any visible pulsation, and you have to determine the site like we said. So here in this image, you can see that this patient has a bulge here. This bulge is a pacemaker used to treat her AV block. So she has a pacemaker for that. And you can see on the chest, she has a scar which is related to a coronary artery bypass graft surgery she had. So she had a cardiac surgery as well. So just by looking at the chest, we can know that this patient is a cardiac patient. So here as well, you can see the pectus excavatum and pectus carinatum. Pectus excavatum is the deflection of the chest wall to the inside. So this is a congenital condition. It's associated with a lot of aortic, mainly aortic diseases. So now we need to check the point of maximum impulse. Point of maximum impulse, a video, I'm not sure why it's not, okay. So we need to check the point of maximum pulse. So we need to check the point when we feel the heart the most. To do it, we need to start by the clavicle, the sternum, and go down to the nipple. And below the nipple, usually it's the point of maximum impulse, 2 centimeters up or 2 centimeters down. Usually we should see it here. When we see it elsewhere, so if we see outward displacement to this maximum point of maximum impulse, so if you put your hand here, you can feel your heart beating the maximum on this area. When you see it outward, so not on this location, you need to suspect right ventricular enlargement. And outward and downward displacement, so it goes down, not just outward, because go down, we need to suspect left ventricular enlargement. And this is related to the anatomy of our heart. So when the point of maximum impulse is shifted, we need to suspect ventricular enlargement in general. So now to auscultate our patient. So we need to put the stethoscope on these points. So the red point is auscultation position for the aortic valve. So when we need to study the aortic valve, we need to put our stethoscope on the red points. It's usually between the second and the third rib on the right sternal border. So this is the right sternal border, and this, between the second and the third, it's the aortic area for auscultation. The blue area also is in the left sternal border this time, between the second and the third rib. Usually this is to auscultate the pulmonary valve. So we hear the pulmonary valve when we put the stethoscope here. We go down now along the left sternal border to the fifth intercostal space. On the fifth intercostal space, it's the auscultation area for the tricuspid valve. So if you have any pathology in the tricuspid valve, you can auscultate it here. And we go down to the apex, so we move to the nipple area and to the lateral aspect of the chest on the fifth, between the fifth and the sixth rib. This is the auscultatory area of the mitral valve. So usually when you auscultate, if you auscultate the patient, you will hear S1 and S2 sounds. So you hear 2 beats for every cardiac beat. It has 2 components, S1 and S2. S1, it's due to closure of the mitral and tricuspid valves. So these are the mitral and tricuspid valve of the right. They close, you will hear the first sound. So it's indicate the beginning of systole when these valves, when ventricular systole. So it's indicate of the beginning of ventricular systole. When the second heart is called S2 sound, it's due to closure of the pulmonary and aortic valves, and after that, diastole will begin. So usually we should not hear additional sounds, but when we hear additional sounds, so we hear not just the 2 beats, we hear an additional sound called S3. This is a low-pitched sound. When we hear it, it indicates also left ventricular dilation. So we saw that left ventricular dilation will cause displacement of point of maximum impulse. It will also cause here a third heart sound on auscultation. Sometimes we hear something called an S4 sound, which is a late diastolic sound just before S1. It indicates left ventricular hypertrophy. So left ventricular hypertrophy is very common in patients with high blood pressure. It's chronic elevated blood pressure. The muscle will become thicker, and we call it hypertrophy. So we'll hear the S4 sound. To know the murmur, so sometimes when you auscultate, as we said, we auscultate on this area, sometimes we can hear a murmur. So to know if the murmur occurs in systole, so we put the stethoscope and we put our hand on the radial pulse. If we hear the murmur with the rise of the pulse, so if you put now your hand on your radial pulse, you can see that the pulse rises and the pulse goes down. So if you hear your murmur when the pulse rises, usually it's a systolic murmur. So the murmur occurs during systole. So like atrial aortic stenosis or mitral regurgitation, these 2 murmurs occurs in systole. But when you hear the murmur with the pulse going down in your radial artery, so this is a diastolic murmur, and usually it's associated with aortic regurgitation and mitral stenosis. So it's very important to make the difference based on auscultation. As you can see here, we have the left ventricle, we have the right ventricle, we have the left atrium. The valve between the left atrium and the left ventricle is the mitral valve, and you have here the aortic valve between left ventricle and aorta, and you have the tricuspid valve between the right atrium and the right ventricle. Usually, the aorta, the blood flow will go from the left ventricle to the aortic valve. When we have backflow of blood from the aorta to the ventricle, this is aortic valve regurgitation. It's a diastolic murmur. So you will hear this murmur with the pulse going down. So this is an abnormality of the aortic valve, which will cause blood flow to go back to the left ventricle, and we call it aortic regurgitation. And you will hear the murmur of aortic regurgitation when you auscultate the aortic valve area. Sometimes when you put your stethoscope anywhere, you can hear a continuous murmur. So during systole or during diastole, it's a continuous in systole and in diastole. It doesn't stop. Usually this is due to an arteriovenous fistula. So a communication between the arterial and the venous system. And the most common communication between arterial and venous system is dialysis patients. They have a fistula between the arterial and venous system in order to perform dialysis. But sometimes you have in the heart a congenital malformation. You have a communication between the aorta and the pulmonary artery. So the aorta is a arterial system, and the pulmonary artery is called artery, but usually it's a venous system because it has blood rich in carbon dioxide. So when you see a communication between aorta and pulmonary artery, you will hear a murmur. This is called patent ductus arteriosus. It's very common in pediatric patients. It will cause a continuous murmur. Now, sometimes you can hear something when you have pericardial inflammation. You can hear something called a pericardial friction rub. I'm putting the sound with the video. I hope you are able to hear it. So this is the pericardial friction rub. I will repeat it once. Okay. So now moving to the lower extremities edema. As we said, patients with heart failure will have bilateral lower extremity edema. It will be a pitting edema. So when we press like this picture, we press here, you can see that when we remove our finger, the pitting edema will persist, so it will not go back to normal. This is very highly suggestive of right-sided heart failure or even left-sided heart failure. So when you see this, we need to suspect heart failure and order cardiac enzymes and lab tests in order to diagnose heart failure and perform an echocardiogram in order to diagnose heart failure. Now moving to the pulmonary system, which is very linked to the cardiovascular system. So we need to check for oxygen saturation. As we said, it should be above 95%. In heavy smoker patients, we can tolerate a saturation between 90 to 94%. So if a patient is a heavy smoker and is a COPD patient, we can tolerate saturations between 90 to 94, and there is no need to put the patient on high dose oxygen in order to treat it. It's normal to have saturation like this. So there's something called tactile fremitus. So we can palpate the vibration of the vocal cord transmitted through respiratory passage to chest wall. So we need to put our both hands on the back of the patient. And when you put the hands on the back of the patient, we need to ask him to repeat number 99 in English, or if we're talking Arabic with him, we need to tell him to say 44 in Arabic. When we tell the patient to say this, we can feel the vibration of his vocal cords. So if it's increased, we suspect conditions like pneumonia, infection of the lungs. When it's decreased, we need to suspect pleural effusion like we see in cardiac diseases, and emphysema like we see in chronic obstructive pulmonary diseases. So it's very important to do this for our patients. And I will show you a video about it.
Against the chest wall, and again have the patient repeat the phrase 99. 99, 99, 99, 99, 99.
So we do this, do exactly like in the video. And if you feel there is increased vibration, so we need to suspect pneumonia. If we decrease vibrations, we need to suspect pleural effusion, so accumulation of fluid in the pleural spaces, and emphysema.
Yes.
So now to auscultate the lungs, these are the locations. So in the anterior chest, we have 4 locations in the anterior, right, left, then we go down, right, left. In the posterior aspect of the chest, we have like the L shape, the L letter shape. We need to repeat the same on the left, on the right side, in order to compare both sides. Sometimes we hear wheezing. Wheezing is when there is narrowing in the airways. So you hear wheezing. It's usually higher in expiration because because chronic obstructive lung disease is an expiratory wheezing. You hear an expiratory wheezing, while in cardiac conditions you will tend to hear more inspiratory wheezing, which are due to heart failure or pulmonary edema or volume overload. So cardiac condition will lead to inspiratory wheezes. This is wheezing, as you heard in this video. Crepitations, which are chord crackles. These are indicates that there's a passage of air through fluid or bronchi and alveoli. So if a patient has pulmonary edema, so accumulation of water in his lungs due to heart failure, you will hear crackles. And you will hear it bilaterally. Usually cardiac edema is bilateral lung crackles. When you hear it unilaterally and in just one lobe, usually it's a lung infection. Okay, so this is the sound of crackles. Okay, now moving to the gastrointestinal tract. So we need to also examine the patient, examine the GI system. We need to do inspection of the abdomen. So we need to check if his abdomen is distended, if his abdomen is distended, if in one side, for example, if he has a hernia. We need to auscultate the abdomen to hear the bowel sounds, to check for abdominal obstruction, intestinal obstruction. We need to do percussion and we need to do palpation. I will show you the image in on the next slides. So inspection, normally the abdomen should be convex from side to side, anterior-posteriorly. Any bulges, we need to rule out obesity, pregnancy, ascites, generalized bulge. So all the abdomen is distended. In heart failure patients, you can have ascites. So you can see the patient with abdominal distension. Fluid will not only accumulate in the lungs and in the lower extremity, they will also accumulate in the abdomen, and the abdomen can accumulate a lot of liters. So a huge number of water can be accumulated in the abdomen, and it's suggestive of heart failure. If you see a localized bulge, just like a large bulge, usually it's not related to cardiac disease, it's due to organomegaly, so liver enlargement, spleen enlargement, or if we have a mass or a cancer, so it will cause abdominal distension. So if the abdomen is retracted, meaning that the patient is in starvation, so he's not eating, he's dehydrated, so it's the opposite to the bulge. And if we have localized retraction, you need to rule out a previous surgical scar causing adhesions or retractions. A very important sign is the Cullen sign. When you see this sign around the umbilicus, we need to rule out intra-abdominal hemorrhage. Intra-abdominal hemorrhage can be related to, for example, rupture of the aorta, rupture of any vascular system, or bleeding from an organ. It will cause abdominal accumulation. In the abdomen, you can see this sign on the skin. It's called the Cullen sign. It also can be seen in pancreatitis, in pregnancy, and in hemorrhagic ascites. So we need to check all these signs. Caput medusa, this condition is related to portal hypertension. You see distension of the veins of the abdomen. Usually it's caused by liver disease and not by cardiac disease. When you see this, sometimes you see the patient that have distended veins on his chest, on his abdomen. We need to suspect liver disease in that case. When we auscultate the abdomen, we need to look for, to check for any abdominal murmur. If we hear, for example, a renal bruit on the kidneys, you need to check, you need to rule out renal artery stenosis. This will cause hypertension. You need to hear intestinal sounds to check, for example, if the intestinal sounds are increased, it indicates sometimes an early obstruction. So we can suspect the pathology associated with the condition just by doing the physical examination. So here is a video. So how to auscultate the abdomen. We need to move the stethoscope to multiple areas and try to hear if the bowel sounds are homogeneous in all the areas. If we hear a difference in the bowel sounds in all these different areas, you need to suspect intestinal occlusion, for example. And here is the location of the renal arteries. So we need to auscultate the renal arteries to check if there is any murmur or bruit. We auscultate also the common iliac arteries to check if there is narrowing. When you have murmur, that indicates a narrowing. And we can also auscultate the beginning of the femoral arteries in the groin area. Yeah, and that's it. Now we have to do something called percussion. So percussion will help us to check if the patient has ascites or accumulation of water due to heart failure. If he has, for example, perforation, I will show you how to do it.
Across the 9 regions of the abdomen, starting furthest away from any tender areas. Air in the bowel usually makes the abdomen diffusely resonant, but this can vary. A full bladder will sound stony dull.
Okay, so we do it like this. If we hear a decrease in when we tap on our fingers, we don't hear a lot of sounds. We need to suspect fluid accumulation. But when we hear increase in percussion sounds or increase in vibrations, in that case, you need to suspect increasing air in the abdomen. It can be due to intestinal perforation, for example. And palpation is very important to palpate. You need to keep looking at the face of the patient to observe painful expression, because it's, sometimes when we palpate, the patient will do facial expression, meaning that he's in pain. Palpating the epigastric area in many cases help us to differentiate if the pain, for example, when a patient presents with myocardial infarction, sometimes the pain is in the epigastric area, it's not always on the chest area. So we can press on the epigastric area. As the pain increases a lot with palpation, it usually indicates a non-cardiac cause of epigastric pain. But when we press and the pain stays the same and does not increase or does not change a lot, usually this is a cardiac pain related to occlusion of the right coronary artery, because the right coronary artery will give blood supply to the inferior wall of the heart, and the inferior infarction will usually give us an epigastric pain. Okay. So we always have to start palpating away from the pain. So if the patient have epigastric pain, for example, we don't start by this area. We need to start by the areas that is not painful. And we move from the areas that's not painful, and we move to the area that is painful. Moving now to the liver. The liver, it's located in the right upper quadrant of the abdomen. So we need to check if we can palpate the liver. So if liver is enlarged, you can palpate it just by putting your hand. So usually liver disease can be related to heart disease, because our discussion is about cardiac diseases. So liver disease, in case of right-sided heart failure, you can see that you can have associated liver enlargement and liver failure from the accumulation of blood, because the heart will fail. So blood will accumulate in the venous system, in the inferior vena cava and the superior vena cava. And you know the liver is directly linked to the inferior vena cava. So when blood will accumulate in the venous system, it will also accumulate in the liver, and it will cause the size of the liver to become enlarged. So liver enlargement usually indicates liver disease, but it can be also associated with cardiogenic shock or congestive heart failure. Chronic congestive heart failure will also lead to a condition, we will call it a cardiac liver. So the liver will fail as well as a result. So here is a
Start the
video.
examination by asking the patient to exhale. Afterwards, as the patient is inhaling, slowly slide your fingers towards the right rib cage so they are near the liver's edge. When the lower liver edge is felt, its surface structure, consistency, and size can be evaluated. Since a severely enlarged liver can extend as far as the lower abdomen, palpation should start further down in the right lower quadrant. If necessary, bimanual palpation can help locate the liver in patients with a large.
Are you able to see the videos and hear the sound of the video or not? Okay, great. So we'll continue. So now we saw how to examine the liver and to check if the liver is enlarged. So now we'll move to the spleen. The spleen is located in the left upper quadrant area, so it's in the opposite quadrant to the liver. And we also need to check for spleen enlargement, for consistency, for the surface, and for tenderness. Usually, spleen enlargement is not related to any cardiac disease, but we always have to examine the patient fully. We need to rule out any other associated pathologies that we can miss easily. So it's very easy to examine the spleen. We just need to palpate the area and we can detect if the spleen is enlarged or not. So we see a video.
It's generally not palpable in healthy adults. A pathologically enlarged spleen is palpated under the left costal margin during inspiration as the inferior edge descends to the examiner's fingertips. If an enlarged spleen is already suspected, palpation should begin further down. The examination may be facilitated by gently lifting the left flank of the patient ventrally.
Okay, so it's like this, it's easy. The kidneys as well, it's very hard to palpate the kidneys, but we need, as we said, we need to auscultate the kidneys or kidney renal arteries in order to look for any murmur, because renal artery stenosis, as we said, it can lead to high blood pressure due to activation of the renin, angiotensin, aldosterone system, which will cause sodium retention and increase in mean arterial pressure. So we have to always do it. We need also to check urinary bladder. As you see, we can see in the hospitals, a lot of patients will become oliguric or anuric, so we will not have any urine from these patients. So we need to check if the bladder is full or not, because some patients who can have urinary bladder obstruction. So when the bladder is obstructed, it doesn't mean that the patient doesn't have urine. It means that the bladder is full, but the patient is unable to excrete the urine to the outside. So we need to examine the bladder to see if it's distended or not. If it's distended with no urine, so we need to suspect an obstruction to the urinary tract. If the bladder is empty and is small and the patient is not urinating, so we need to suspect conditions like cardiogenic shock or any other type of shock, which will cause a hypoperfusion to the kidneys. So the blood supply to the kidney will stop. So we will have loss of filtration in the kidney. So we have no urine. So we need to, it's very important to check the bladder. We can do also ultrasound echography to see the bladder, to see it if it's filled or if it's collapsed. And I think I will stop here. So thank you. If you have any question, I'm ready to answer. Okay. So I think we will take 5 minutes break and we'll continue to with the next presentation. So 5 minutes and I'll be back, okay? Hearing me and are you hearing me and are you seeing the slides? Okay, perfect. So now we move to this topic, which is the pain management for stable and unstable angina. So stable and unstable angina is a chronic condition affecting the heart. It's a very complicated topic, but I will try to make it as simple as possible. So we'll start by some prevalence. So chronic ischemic heart disease epidemiology. We have 17 million Americans that have chronic coronary artery disease. And from these 17 million American CAD patients, we have 10 million Americans that reports chest pain of any level. So they will come to the emergency department or to our clinic with chest pain. And from these patients that are between age 60 to 79, 25% are men and 16% of women will report angina. And from patients that are above 80, 37% of men will report pain and 23% of women will report pain. So angina is more frequent in male patients that have CAD, and it's less frequent in females. So in the US, they do around 1,300,000 PCI every year. So they put 300 stenting procedures. Surgery is a bit less frequent and it's going down year after year. We have around 148,000 coronary artery bypass graft to treat coronary artery disease every year. And we have a lot of, if you see the economy, $13 million for ischemic heart disease visits, the cost, and the cost for emergency department visits. So when patients have angina and they will present to the emergency department, this will cost the country $922 million. And the long-term care, so the treatment and the follow-up and the insurances and everything will cost $2.6 billion every year just for stable angina and coronary artery disease. So it's a very, very big number. That's why the target of cardiology prevention is to decrease the cost of this disease. So moving now, how can we grade the angina? So if a patient comes with stable angina and you have chest pain, how can we grade it? So class 1 is a patient with CAD but has no angina. So he walks, he can go up the stairs, and he will report no symptoms and no angina. This is called the class 1 CAD. But when the patient will tell us that he has slight limitations, so when he begins to have angina when he's walking rapidly, or after a meal, or when climbing the stairs, or when he's walking outside in the cold in the morning, this is called class 2 angina. So class 2 is pain that causes slight limitation. So he can continue to live with it. It will not influence his daily activities. Class 3 angina is a pain that will cause marked limitation. So he can tell us that he walks just 1 or 2 blocks and he has to stop after. If he climbed just 1 flight of stairs, so just 1 floor, he will need to stop in order to rest. This is called class 3 angina. Class 4 angina is the unstable angina, is the patient that is unable to do any activity because of chest pain, and he has even chest pain at rest. So this is class 4 angina, and we call it unstable angina. So it's a pain at rest. The others are pain with movement. Class 1, class 2, class 3 don't have any pain at rest. So why do we have angina? Because of the atherosclerosis. So atherosclerosis is the narrowing of the blood vessel. You can see we have progressive narrowing. We can see the plaques. We can see the plaque that's occluding the vessel progressively. So as the plaque grow in size and the vessel diameter and vessel lumen go down in size, we will have increasing angina. Okay. So the ischemic cascade, how it will reflect clinically. So first we can detect changes on the ECG. We can detect abnormalities on the ECG, like T-wave inversion, like ST segment changes. All these indicate ischemic changes. It can cause global systolic dysfunction. So if you do an echocardiography to our patient, you can see that the ejection fraction can drop from coronary artery disease because the coronary arteries will give blood irrigation to myocardium. So if we have less blood irrigation, you will have decrease in the contractile function of the myocardium. We can have regional wall motion if just one artery is affected. For example, if the right coronary artery is affected, we will see the inferior wall of the heart will not be able to contract properly because it's supplied by this artery. So we can have also diastolic dysfunction. So the heart can pump normally, but it can't relax. So it can't be filled normally with blood. The pressures will rise and the blood will not be able to move from cavity to cavity inside the heart. And we can have vascular dysfunction as well as a result. And all this cascade will lead to increase in mortality and at the end due to ischemia. So how can we classify angina? We classify them as low risk patients, so less than 1% annual risk of death or myocardial infarction. So these patients have no ischemia, no ischemic sign when we do the exercise stress testing. So they can perform the exercise testing. So we ask them to walk on a treadmill, and if we use the ECG, we will detect no changes on the ECG. We'll detect no arrhythmias. So, and if we do a coronary angiography or coronary CT scan, we have no stenosis above 50%. So all our stenosis are less than 50%. And if we do the calcium score is a test based on a scan as well to detect the amount of calcium present in the vessels. And when the calcium amount is less than 100 Agaston units, it's usually a low risk for the patient. So all of these features together combined in a patient with angina is a low risk angina. Now moving to the intermediate risk angina. So we have 1 to 3% annual MI or myocardial infarction or annual death. And this is when the left ventricular ejection fraction starts to drop. So we have ejection fraction between 35 to 49, which is called reduced ejection fraction. When the calcium score, for example, is above 100 and less than 400, so it's an intermediate risk. When you have stenosis on the coronary artery, when you do imaging and we see stenosis between 50 to 69%, this is called intermediate risk. And when we see changes on the electrocardiogram, so we see ST deviation of more than 1 millimeter after stress test, this is called intermediate risk as well. So the mortality will increase from 1 to 3% in patients with intermediate risk as compared to low risk. Moving now to high risk patient, meaning that we have a more than 3% annual myocardial infarction or annual death. These patients usually have a lower ejection fraction less than 35%. They have a calcium score of above 400, so it's a very high calcified vessels. If we have coronary artery lesions of above 70%, so significant narrowing of coronary vessels. If we do an exercise test, and we can have, for example, arrhythmias like ventricular tachycardia, ventricular fibrillation during exercise. This is a very bad sign. And you can have a ST deviation as well of above 2 millimeter. This also indicates a poor prognosis, and ST deviation on the electrocardiogram when you do the ECG. So it indicates a higher risk for patients and increased risk of death. Okay. Okay. So now, how can we put these patients on medical therapy in order to treat their ischemic heart disease? So first, we need to implement guideline directed medical therapy. We just can't put any medical therapy we think is correct. We always need to follow the guidelines. And the recent guidelines are provided by the American College of Cardiology. So we start with aspirin 75 to 162. So it depends on country. So here in France, for example, we have the aspirin 75 milligrams. In other countries like Lebanon, for example, we have the aspirin 100 milligrams. So it depends, but it's the same efficacy for aspirin between 75 and 162 milligrams. It has the same efficacy on the coronary artery. And if the patient is intolerant to aspirin or has allergy to aspirin, then we can use clopidogrel, for example, instead of aspirin. So we have the option to switch aspirin with clopidogrel for patients with stable ischemic heart disease. Here we're not talking with acute coronary syndrome, so we don't need to put both drugs together. You just need to put one. We're talking about stable angina and stable ischemic heart disease. So after putting aspirin, we need to do lifestyle modification for every patient. So we need to change the diet. We need to do weight loss. We need to do physical activity, regular physical activity. And we need to tell the patient that he needs smoking cessation program in order to try to smoking if he is already a smoker. After implementing these measures, we need to give a symptomatic treatment in order to alleviate the anginal symptoms. So how do we treat this angina? Usually, we can give a nitroglycerin sublingual. So nitrates are drugs that will cause venodilation, so they will dilate the veins. When dilating the veins, they will decrease preload to the heart, so they will increase the pressure on the heart, so the heart will be able to pump blood in a more relaxed fashion. So that's why when we give nitroglycerin sublingual, will cause venous dilation in the body. So that's why it will cause relaxation of the myocardium. That's why the anginal symptoms will decrease very rapidly, because it has a very fast it acts very fast. So in a few minutes, it will give us a decrease in angina. Okay, I don't know why the slides, I can't move the slides. Okay. Okay, so we need also to, every patient with ischemic heart disease should be on a high dose statin. So we need to put atorvastatin or rosuvastatin. These are the two statins that are called the high intensity statins. Atorvastatin ranges from doses from 40 to 80 milligrams, and rosuvastatin 20 to 40 milligrams. Both of these drugs can be used in ischemic heart disease. And we need to target treatment for high blood pressure. For example, if a patient is high hypertension, we need to drop his blood pressure of less than 140 to 90. And now we need to drop it of less than 130 to 80. We are more aggressive with the newer guidelines. And we can use angiotensin converting enzymes inhibitor, angiotensin receptor blockers, especially if our patient has LV dysfunction associated with high blood pressure. So the ACE inhibitors will improve his LV dysfunction and will treat his blood pressure simultaneously. And if the patient has diabetes, so we need for sure to put him on the appropriate diet and put him on the appropriate medications. So now if we give our patient sublingual nitroglycerin, but the patient remains in pain. So if the angina persists with sublingual nitroglycerin, which is the main topic of this course, what we can do next? So next we can put him on a beta blocker. Beta blocker is medication like bisoprolol or nebivolol, which are used to decrease the heart rate. So by decreasing the heart rate, we will decrease oxygen demand to the myocardium. So when we decrease oxygen demand, we will improve the symptoms. So we will decrease angina. For sure, if we have no kind of contraindication to beta blockers, for example, like acute asthma, for example, because beta blocker will cause bronchoconstriction. If we don't have decompensated heart failure, because decompensated heart failure, we should not drop the heart rate. At the opposite, we have to increase it. So here we're talking about patients with stable ischemic heart disease. If needed as well, we can put calcium channel blockers or long-acting nitrates to cause also vasodilation. Vasodilation will decrease work on the heart, so the heart will be relaxed when pumping, so the angina symptoms will resolve. And we have another medication called ranolazine. We'll discuss it later on. If despite using all this medication, our patient remains symptomatic, so in that case, we need to do invasive testing. So we need to do coronary angiography. We need to check his coronaries to see if he has a severe lesion causing his symptoms. So if we do a coronary angiography and we find a significant lesion, for example, an artery that is stenotic of at level of more than 70%, in that case, we need to proceed with revascularization. So it's either we put a stent inside this lesion, or we do surgery if we have multiple lesions, simultaneous multiple lesions. So when the symptoms does not improve with medical therapy, we need to do more aggressive, more invasive therapy. So now when we move, this is it's like a summary. So angina relief, first line, we need to put the patient on short-acting nitrates. So when we put the patient on short-acting nitrates, we need to put with it either a beta blocker, a calcium channel blocker, as we said, to cause vasodilation, or sometimes we can do combination of beta blockers and calcium channel blockers together. And if this patient is still symptomatic, we can use second-line medications that we will discuss in the next slides, like ivabradine, long-acting nitrates, nicorandil, and ranolazine, and trimolazine. So we have a lot of options for relieving anginal symptoms. And as we said, if the anginal symptoms persist despite this first and second line medication, we need to do angiography, and if needed, put a stent, so PCI, or if needed, do a cabbage surgery to treat his coronary arteries. And we need also to prevent, so lifestyle modification, coronary control of risk factors, and we need to educate patients and put him on appropriate diet to reverse his disease, to put him on aspirin, statin, and ACE inhibitors and ARBs. Aspirin, statin will not affect the angina symptoms. They will just affect the atherosclerosis, and they will slow the progression of the disease, but they have no effect on the angina symptoms. So the educational plan should be about medication adherence, which should tell the patient that he is not allowed to stop any of his medication. We need to explain, encourage him to do daily exercise, and we need to explain to help him recognize his symptoms. So when you have a typical cardiac symptoms, we need to explain to him before symptoms happen that he needs to seek medical visit, like going to the emergency department when he has chest pain, for example. And we need to propose to him all the available therapeutic options and take his opinion, because patients should also participate in the decision making, of their own decision making. And we need to educate them to adhere to a low salt diet, low fat diet, and low cholesterol diet. And we need to increase the fruit, increase the vegetables, and increase the grains, as we said in the first session today. We need to do behavioral changes, right, to decrease the stress and look for depression, because we know that depression is associated with a lot of cardiovascular diseases and can increase increase the cardiovascular diseases on the long term. And if we find depression, we need to treat depression by using medications like SSRIs or tricyclic antidepressant, but we should send the patient to a specialist. So the class 1 recommendation for blood pressure managing in ischemic heart disease. So we start first, like every time, by lifestyle. So weight control, physical activity, sodium restriction, fruits, vegetables, and low-fat dairy. And we need to start treating if the blood pressure goes above 150 to 90. So when we become in the stage 1 hypertension category, we need to start treating. And we have a lot of options to treat blood pressure in ischemic heart disease, but the best options are ACE inhibitors and beta blocker, because ACE inhibitor and beta blockers, they also have positive effects on the heart. So we use them more than calcium channel blocker and more than thiazides diuretics. So you can see here that when the blood pressure goes up, so you can see the red curve, the blood pressure is going up, the systolic and the diastolic. It's associated with adverse outcome and increase in cardiovascular events rate and increase in mortality. So blood pressure is a very significant risk in patients with ischemic heart disease. So we're talking here of stable and unstable angina patients. I'm sorry. So the recommendation in diet intake, so you know that we need to decrease saturated fat for less than 10% of total energy intake. We need to decrease salt to less than 5 grams a day. We need to increase fibers to 30 to 45 grams per day, and we need to divide them in multiple episodes. We need 200 grams of fruit per day and 200 grams of vegetable per day in 2 to 3 servings. We need to eat fish twice a week, one being an oily fish, and we need to reduce the consumption of alcoholic beverage of not more than 2 glasses per day for men and 1 glass per day for women. So we need to have low alcohol intake, especially for pregnant women who should stop alcohol completely. So in stable ischemic heart disease, so stable angina and hypertension, we have to treat hypertension, we have many options. So if you have heart failure associated with this condition, we can use diuretic to reduce the volume. You use beta blocker to decrease the oxygen demand on the heart. You could use ACE inhibitor because ACE inhibitor will improve remodeling. And myocyte remodeling is very implicated in the heart failure, and it causes heart failure progression. So we need to stop this process. If we have LV dysfunction, so like the case of heart failure, ACE inhibitors are very effective. Post myocardial infarction, every patient with myocardial infarction should be on a beta blocker and ACE inhibitor. So it will treat his high blood pressure, and it will treat his myocyte remodeling to prevent heart failure. Angina, we should use beta blocker, as we said, when you have anginal symptoms and pain. Beta blocker are effective alongside with nitrates to treat hypertension as well. Diabetes will also benefit from beta blocker and for ACE inhibitor in order to prevent progression of diabetes and prevent complication of diabetes like diabetic nephropathy. So ACE inhibitors are very helpful, and they are kidney protective medications as well in diabetes. CKD as well, we need to use kidney protective medications like ACE inhibitors. So it's we have many options, and we can combine these medications together. So physical activity is class 1 recommendation. We should do 30 to 60 minutes of moderate intensity aerobic activity at least 5 to 7 days a week. So at least 5. We need to push the patient to do daily exercise as possible from 30 to 60 minutes. And if, for example, the patient tells us that he is unable to perform the exercise, so we need to suspect that he is progressing with his disease. So we need to be more aggressive with the treatment in that case. And we have to do supervised programs for patients at first diagnosis. So the exercise should be supervised by specialists. Okay, so weight management as well in stable coronary artery disease, in stable angina, we should measure the BMI and waist circumference, and we should encourage weight reduction. So we should target a BMI of 18.5 to 24.9 in patients with stable angina, and we should target a waist circumference range from 102 in men and less than 82 in women. And we need to target a 5 to 10% weight loss from baseline. So this should be our initial target, to drop the BMI, to drop the waist range, and to decrease the weight in general by 5 to 10%. This is class 1 recommendation by the American College of Cardiology. Okay, so moving now to smoking in stable angina, it's also encouraged to stop smoking. We need to avoid environmental smoke. We need to refer patients to referral programs, and to use pharmacologic therapy like nicotine replacement therapy. You have the patch and you have the nicotine gum that helps in smoking cessation. And we have these 6 questions. So if we need to know if a patient, if still smoking, we need to ask a patient about tobacco use every time, to advise him to stop. So the 6 A's: to assess willingness to make quit attempt, and to assist in quitting, so to prescribe medication and refer him to a specialist, smoking specialist. And we need to arrange follow-up and avoid the exposure environmental smoke. So we need to do this in every visit. Depression can also be associated with stable and unstable angina and stable ischemic heart disease in general. So we have to ask the patient that if in the past 2 weeks he have been bothered by any of the following problems. So we need to ask him 9 problems, these 9 questions, to see if he's really having a depression episode. So we'll not go into details, but for example, we can ask him if he's losing interest or pleasure in doing things, if he's feeling down, if he has poor appetite, for example, or overeating, because poor appetite or overeating can be associated with major depressive disorders, if he's not able to concentrate on things that he used to concentrate before, if he's thinking that he's better to be dead than follow this aggressive treatment or aggressive consultation. So all these will indicate that the patient has depression associated with his stable angina. And it's very recommended for all patients to recommend them to do the annual influenza vaccine, because patients with influenza vaccine, they are at increased risk of cardiac complications. Yeah, influenza infection can cause a decompensation in a patient with a stable heart disease. So when exposed to influenza, there's a high risk of deteriorating. Same for COVID-19. So we should encourage our patient to receive the vaccines as recommended, and to avoid the contact with a patient with respiratory infection because of the risk of influenza and coronavirus as well. So we have other class 1 recommendation for chronic coronary disease like stable angina. So we need to check his lipids annually, to monitor his glucose annually, and to measure his creatinine each few months or 1 year. And we need to do a carotid ultrasound once, because we know that carotid disease can also be associated with heart disease. We need to do echo to exclude the low ejection fraction, because we said in the previous slides, in the first slides, that a drop in ejection fraction will increase the risk of mortality from 1% to 3% and maybe 5%. And we need to do ECG to check for if his patient is doing an acute coronary syndrome and not just a stable angina. And we need to do a chest x-ray if the pain is atypical. For example, if we suspect a pulmonary disease and we're not suspecting a cardiac disease, because as you know, pulmonary disease like pulmonary emboli or infections can cause also chest pain. So it's always recommended to do all these exams for patients that are in stable coronary artery disease. As for the medical treatment for stable angina, we need to put the patient on aspirin, as we said, 75 to 160 milligrams. And if he's unable to tolerate aspirin, we should switch him to clopidogrel, which is a P2Y12 inhibitor that will act on to decrease platelet aggregation. Association sometimes we can associate sometimes clopidogrel and aspirin, even if we don't have an acute coronary syndrome, and especially in patients with high risk, for example, patients that have 80 to 90% lesions on coronary angiography, for example, if they are diabetic. If we think they have polyvascular disease patients, we can put them on double antiplatelets, but it's not very recommended. It's class 2B. So class 2B, we can do it, but it's not very recommended by the guideline. And we have an old drug called dipyridamole. It's an old drug. It's now class 3 recommendation to use it. We should not use it at all. So we should stop this drug. If we see a patient on this drug, we should stop it and switch him to aspirin instead. So beta blocker, as we said, beta blocker will help decrease anginal symptoms, as we said, because they will help decrease oxygen demand by the myocardium. So symptoms angina will reduce. And we should know that a beta blocker, if the patient developed acute coronary syndrome, so we're not talking here for stable angina, so ST elevation and myocardial infarction or non-ST elevation myocardial infarction, we should use beta blocker for a period of 3 years after myocardial infarctions, but not for every patient with stable angina. So we should use also beta blocker in patients with stable angina and EF ejection fraction less than 40%, because you know that beta blocker are very helpful in patient with heart failure. Okay. And beta blockers also should so we should use beta blockers carefully. So we have indications for beta blocker like acute coronary syndrome and LV dysfunction. Okay. So you can see here that routine use of beta blocker in just stable angina has no benefit. So if you don't have associated acute coronary syndrome or drop in LV ejection fraction, you can see that the usage of beta blocker or no beta blocker, the two curves on the 3 graphs are the same. So there is no real benefits in using beta blocker just for patients with stable ischemic heart disease. ACE inhibitors, for example, should be prescribed in all patients with stable ischemic heart disease. Should be used if we have also hypertension, diabetes, or drop in LVEF or CKD. So we said that ACE inhibitor also have an indication. So it should not be for all patients with stable angina. It should be just for patients with stable angina associated with hypertension, diabetes, and heart failure. Angiotensin receptor blockers should be used as a patient is intolerant to ACE inhibitors, so they are used as the second line. And that's it concerning ACE inhibitor and angiotensin receptor blockers. So you see here that patient in stable coronary artery disease without heart failure. So there's no reason to use ACE inhibitor, because you see using ACE inhibitor is the first line, and the no ACE inhibitor and no ARB in the second one, they are the same on cardiovascular death, MI, and stroke. So there is no indication to use this drug in just stable coronary artery disease without hypertension, without diabetes, without heart failure. So now we move to the drugs that we said we use for pain. We said at the beginning that we use short-acting and long-acting nitrates in order to alleviate angina, but these drugs have a lot of side effects. When we dilate the veins, we will cause headache, flushing, hypotension. We can cause syncope or orthostatic hypotension, or it can cause reflex tachycardia. And we should avoid these drugs in patients that have hypertrophic obstructive cardiomyopathy. So these drugs have a lot of side effects, and we should be very, very cautious in using them, and they have a lot of drug-to-drug interactions with other drugs, and mainly drugs that cause lowering blood pressure, so will cause hypotension if we combine drugs. Beta blocker as well, we said that beta blocker can be used to alleviate pain, but they have also a lot of side effects like bradycardia, heart block. They can cause bronchospasm, so we should take precautions in patients with COPD and asthma, because already these patients have bronchospasm. So there's a risk of increasing bronchospasm. So these beta blockers are contraindicated in acute asthma, so asthma with wheezing or auscultation. In COPD, we should be use it with caution. It's not contraindicated, but we should use it with caution. If we have decompensated heart failure, we said we should not drop the heart rate. We should increase the heart rate in order to increase the cardiac output. So beta blockers are to be avoided in cardiogenic shock. So we said that there's a drug called ivabradine. Ivabradine will act on the we call them the funny channels in the heart. These channels are a mixture of sodium and potassium channels that will cause sodium and potassium to go from inside to outside the cells. These drugs work by also decreasing the oxygen demand on the myocardium by dropping the heart rate. And as you can see, when we compare ivabradine, which is the gray panels on this chart, you can see that ivabradine is a lot effective in increasing exercise tolerance and decreasing anginal pain. So ivabradine is a very effective drug, but you will see later that it's not. To use it, we need a special condition in order to use it. So now moving to the calcium channel blockers, we said that also calcium channel blockers can alleviate symptoms of angina. We have the calcium channel blockers that cause heart rate lowering, and we have the calcium channel blockers that will cause blood pressure lowering, so the vasodilation. So both can also has a lot of side effects like bradycardia, they cause headache, constipation, flushing. So it's we should use them very carefully. And they have contraindication, same as beta blocker. We should not use them in decompensated heart failure. We should not drop the heart rate in decompensated heart failure. We should increase the heart rate. We should not use them in low blood pressure and in obstructive cardiomyopathy as well. Ivabradine, the drug that we discussed now, the drug that acts on the funny channels of sodium and potassium in the myocardium. These drugs also have had a lot of side effects like visual disturbances, headache, bradycardia, atrial fibrillation, and heart block. and they tend to lower the heart rate. So it's contraindicated if the heart rate is low. And some patients have severe allergies to these drugs, so we should be very careful with it. It should be used with precaution for patients that are above 75 years of age, because it can predispose to cardiac arrhythmias at that age, and it can cause a worsening of renal failure if a patient has already renal failure. Other drugs that are second-line drugs, so not very used, I will go over them quickly. So we have the nicorandil, we have the trimetazidine, ranolazine, allopurinol. You can see they have huge side effects, so we have a lot of side effects, so we need to be careful. We have a lot of contraindications for these drugs, and we have to take precautions mainly for elderly patients and patients that have renal impairment and renal failure, because these drugs, they act on the kidneys and they can worsen the renal dysfunction. So that's it for the drugs. So what is not recommended in stable angina? You can hear a lot of people taking, for example, vitamin C to alleviate the angina. A lot of patients will take vitamin E, for example, beta-carotene, folate, vitamin B6, vitamin B12. All of these medications have no benefit, so they are not recommended, and they are classed as class 3 in the American College of Cardiology guidelines. So there is no need to use these things in order to relieve anginal symptoms. Okay, so now if our patient, we said we put all this treatment and we implemented all this therapy together, and the patient remained symptomatic. So we said that we need to check his coronary arteries by doing a coronary angiography. So if we find a narrowing in the vessel, so it depends on the number of vessels, we will see how we take the decision. It's either we do PCI, so we put a stent, or we do a surgery, like we do coronary artery bypass graft surgery, or we can do a combination of both, which we call it a hybrid therapy. So we do put a stent and we do surgery for the same patient at the same time. So how to decide between either if the patient is still symptomatic, do we find a coronary lesion on invasive testing? So how we decide? We have a syntax score. Syntax score help us classify patients. So it's a very complicated score. We'll not go over it in details. You just have to know that this score exists, and in order to have the score, we need to check which vessel is occluded, because every occlusion in a vessel will give you a different score. So we see that if we when the score goes up, so you see here's the curve on the right. So when the score go from 5 to 20, you can see that one risk of death goes up from 0% to 20%. So the syntax score is a very predictive score, as well as mortality, not just a score to help us decide which revascularization process to use. So here you can see a study. It's called a Courage study. It was published in the New England Journal of Medicine. It's a study that shows the rate of major adverse cardiac or cerebrovascular events among the study patients. So here they did PCI and they did CABG for patients with low syntax score. They found that PCI, so stent, and surgery is the same for patients that have a low syntax score. So we can do both if the syntax score is low. But when the syntax score is intermediate, it means it's a bit elevated. In that case, you can see there's a small benefit of coronary artery bypass graft as compared to stent. So when the score goes up, there's a benefit of surgery over stenting. And when we are in the high syntax score, so very high score, here CABG is a lot more beneficial than doing PCI and then doing stenting, so we reduce mortality on the long term. So this study as well, it's called the CID Syntax 5-year results. It showed similar results. It was published in the Lancet journal. So we have also different considerations. So if we have a number of coronary arteries with relevant stenosis in proximal segment, for example, we need to check if the artery is, we have the lesion in the proximal segment or in distally. So when we have a lesion in the proximal segment, it's a lot more severe. So if we have one or two vessel disease, just one or two vessel disease, without proximal left anterior descending involvement, left anterior descending artery is the primary artery of the left ventricle. So if this artery is not involved and we have just one or two vessel disease, so here we do a stent. Directly we can do a stent without any doubt. But when we have one or two vessel disease plus the proximal left anterior descending artery involvement, here we should do a medical and surgical discussion. So cardiologist will have to discuss with surgeon in order to take the heart team discussion and proposition to the patient. So it's either stents or CABG. But when we have three vessel disease, so we have multiple vessel disease, in that case, we need to look for the syntax score. If the syntax score is less than 22, so it's a low score. So we said in the previous study that we can do both. It's either stent or either surgery. So we need also a heart team discussion in order to decide. But if the syntax score is high, above 23, and the patient is at low surgical risk, in that case, we can proceed to coronary artery bypass graft directly without requiring a surgical discussion. When we have left main coronary arteries, so left main is the artery that will bifurcate and give left anterior descending artery and left circumflex artery. It's the major vessel of the heart. If this vessel is occluded, we'll have a mortality after it. So if left coronary artery is occluded, had a lesion in the left main coronary artery, we need to check if we have associated vessel disease. So if we have 2 to 3 vessel disease associated with the left main, we also look for the syntax score. But here the syntax score is 32. In the previous slide, it was 22. So when we have a left main involvement, we need to have a higher syntax score. So if the syntax score is less than 332, then we can do a heart team discussion to decide if we put a stent in the left main artery or if we do surgery. But if the syntax score is high, we directly go to surgery. As we said, there is no need to do discussions in this case. Here is a study. So they did this study. It was published in the New England Journal of Medicine as well in 2016. They used everolimus eluting stents, so a stent containing a drug called everolimus, which is an immunosuppressant drug, or bypass surgery for left main coronary artery disease with syntax score less than 32. And this study showed showed nearly same benefit for both ways. So revascularization with either a stent or CABG shows no major difference. There was just a slight advantage for stenting as compared to surgery as related to death, stroke, and myocardial infarction. But when they used death from any cause, there was no difference in the two procedures. So there was just slight benefit for PCI over CABG for patients with left main disease and syntax score of less than 33. Here is another study as well. They compared as well stenting to surgery in left main stenosis for patients with here syntax score above 32. So in the previous study, it was syntax score less than 32. Here they compared, they used the syntax score above 32. So it's a more dangerous disease. And they found that all-cause mortality was higher in the PCI, so in the stent, as compared to CABG. But the cardiac death was 3% in both groups, so there was no big difference in cardiac death. But the only significant difference was, you can see the p-value is 0.0066, so it's less than 0.05, so it's significant, statistically significant, is MACE. So MACE was better with CABG. So that's why they recommended CABG for patients with syntax score above 33, and PCI or cabbage if the syntax score is less than 32. Here is another trial as well. You can see that for these patients, it was nearly, it was a bit in favor of cabbage as compared to PCI. So 5-year event rate of 26.6 in PCI and 18.79 in cabbage. The problem is for patients with left main coronary artery disease and with diabetes. So as you know, diabetes is associated with morbid complications on the coronary vessels. So when diabetes is associated with left main disease, it's recommended to do surgery, not stenting, because diabetic usually have small arteries and tortuous arteries. So it's very difficult to put a stent in these types of arteries. So that's why they recommend coronary artery bypass graft by surgery. You can see there's mortality benefit for cabbage when we treat left main disease in diabetic with cabbage. So 10.7% morbidity after surgery versus 15.7% morbidity when we treat by a stent. Okay. So here is also when we, so the mortality is in favor of, as we said, in favor of cabbage. So what is new, as we said? So cabbage, the surgery, is now class 1 in patient with left main disease and diabetes. So it's a class 1. But when we have left main disease without diabetes, then we need to look for the syntax score. If the syntax score, as we said, is above 34 or 33, we do surgery. If it's less than 32, we do PCI to treat the stable angina and these anginal symptoms for our patients. Okay, so and there is no benefit, for example, to measure, to do an echo, for example, for routinely. So there is no need to tell the patient to come back 3 months later to repeat the echocardiography to see if the ejection fraction has dropped. We only do echography if we have new symptoms. So if the angina is increasing and not responding to therapy, then it's indicated to do echocardiography to evaluate the heart function. It's not recommended to do echo if there is no change in clinical status or symptoms. So it's class 3 recommendation to do a routine echocardiography. Here is another study. I will go in it briefly. In this study, they used something we call fractional flow reserve, FFR, versus angiography to guide stenting. FFR is usually a method we use when we find an intermediate lesion on a coronary artery. For example, we find a 60% lesion, and we're not sure if this lesion is significant or not, because as you know, to put a stent, you need to have a lesion that is above 70%. So if it's 60%, for example, we can do FFR to make sure. If the FFR results came back positive, so this lesion is significant, and this lesion, we should put a stent on it. If it's negative, there is no need to put a stent, and we continue medical therapy. And in this study, they compared using FFR to stent or just using visual estimation of the physician to put a stent, so not using FFR. And they found out in the study that there is a benefit in FFR. You can see the orange chart here is for FFR, and the green one is for angiography group. So visual assessment by the cardiologist. And they found out that there's benefit in DES-MI and repeat revascularization in a group that went to the FFR guided, decrease in DES, decrease in MMI, and decrease in repeat revascularization. And this is the two curves. The FFR curves has increase in survival over 5 years as compared to the angiography guided PCI that had lower survival rate after 5 years. And we need to ask the patient to come for annual checkup, to check for his symptoms, to check for his heart failure symptoms, to check for angina symptoms, to modify his risk factor, and to implement adequate treatment. Okay. So as we said, there is no benefit to do a routine echocardiography or routine imaging test. As we said in the previous slides, it's now considered as a class 3 recommendation. And if we do it, we can repeat it 5 years later and not before if there's no change in symptoms. And here are the recommendation by the guidelines. It's recommended that all patients receive secondary prevention and to be scheduled for follow-up visits. So after revascularization, we need to see the patient a few weeks later to make sure all is okay. We need to instruct them to return to work and retake full activities for sure after doing rehabilitation for this patient. We need to put him on aspirin. All patients with angina should be on aspirin. Dual antiplatelets is only recommended for acute coronary syndrome. So we need to put the patient on double antiplatelet for 12 months if we put a stent and we have an acute coronary syndrome. So we should follow these rules in order to treat stable anginal symptoms. The last slide I will show you here is a study that was published in the JACC, Journal of American Cardio Journal. So in this journal, they evaluated patients based on their symptoms. So patients with non-anginal chest pain, so chest pain that increased, for example, with palpation, it's not an anginal pain. Patients that have atypical angina is like a pain that increases with inspiration. And typical angina is the angina of cardiac origins that you know, so the oppressive angina, it's the retrosternal, it's the typical cardiac angina. And they evaluated this patient to see if they have underlying cardiac disease. And you can see that patients with non-anginal chest pain, so it's a very atypical angina, they, for example, if they are between 30 to 39 years of age, just 4% of these patients with this type of angina have underlying cardiac disease. But when the age becomes between 60 to 69, you can see that 27% of men with non-anginal chest pain have actually cardiac disease, underlying cardiac disease. So it's a significant number. 27% of patients with this type of patient have cardiac disease. So we need to always ask for cardiac biomarkers in order to rule out troponin levels, in order to rule out underlying cardiac disease, even if the chest pain is not very typical. So we tend to do this. And you can see, for example, that patients with typical angina, aged between 60 to 69, they have around 90% chance of this be related to actual cardiac disease. So it's very high. So the typical angina is very, very predictive of underlying cardiac diseases. And that's it. If you have questions, you can ask me for sure. Thank you. It's a very complicated topic, so I tried my best to simplify it, but even with this, it's still a bit complicated. Okay, I think we can now take a 5-minute break and we'll continue with the next session. It will be about hemodynamic monitoring. So we'll just take a 5-minute break because so we will be back in 5 minutes, okay? Okay, so can we continue now? Are you seeing the slides? Okay. Okay. So I will start. We'll talk today about hemodynamics. So as you can see, hemodynamics have not changed a lot. So these slides are from an article published in 2003. Hemodynamics is still the same because it's based on cardiac anatomy and on cardiac physiology. So we don't have a lot of changes concerning cardiac hemodynamics. So we'll start by talking about the cardiovascular system. First, we start talking about the cardiovascular anatomy. So it's a closed system of the heart and the blood vessels. So the heart will pump the blood, and the blood vessels will allow the blood to circulate to all the parts of the body. So it's a pump, and like vessels will be used to transport the blood to different organs. And the function of the cardiovascular system is to deliver oxygen. So the main function is to give oxygen and nutrients to the organs, like the liver, the kidneys, and the brain. These are the vital organs, and to remove carbon dioxide and other waste products. So we give the organs oxygen and nutrients, and in the opposite, we take carbon dioxide and waste products in order to take carbon monoxide to the pulmonary artery in return to the right side of the heart, from the right side of the heart to the pulmonary artery, and then to the lungs in order to do gas exchange. So it's like a system that is directly linked to other organs like the lungs, the heart, the kidneys, and the liver, and the brain. So the heart is localized in the thorax between the two lungs, and it's pointed, the apex of the heart is pointed towards the left hip. So if you put your hand on the left hip, the apex of the heart is pointing toward this left hip, and it has about the size of your fist. So it has about the size of 1 lb. So the heart, as you can see on the first image, I will try to use a pointer. So the heart is located here. It's between the second rib and the diaphragm inferiorly. And you can see in this image that we have the pulmonary, this is the heart. We have the pulmonary artery going from the right ventricle to the lungs, and we have the aorta that is going from the left ventricles in order to reach the different organs. And the heart is encircled by the pericardium. You have the parietal pericardium, and you have the pleural space here of the lungs. So it's a very compact system. So it's very prone to injury as well, because of especially penetrating injury. So we'll continue with the anatomy. So the heart is covered by the pericardium. So pericardium is the outer layer of the heart. It's a double serous membrane, which contain the visceral. So it's divided into the visceral pericardium, which is directly related to the heart, and the outer space. So the pericardium is divided into the inner space, which is the visceral pericardium, and the outer space is the outside layer, which is the parietal pericardium. And there's a fluid that is serous in nature. So it's not bloody, it's serous fluid, so that fills the space between these two layers. The pericardium has a lot of effect because the pericardium will allow the heart to move in this very compact system. So this fluid will allow the heart to swing inside and to move. So especially in case of the cardiomegaly, for example, in heart failure or in other conditions. So the heart itself now, not the pericardial layer, is divided in three parts. We have the most inner part, which is in contact with the blood inside, which is the epicardium. It's it's the endocardium. The most inner layer is the endocardium. It's the layer that is in contact with the blood. After that, we have the myocardium, which is the muscular layer. The muscular layer is the layer that is responsible for myocardial contraction and for the pump activity of the heart. The most outer layer of the heart is the epicardium. It's the layer that is next to the parietal pericardium, and it's a form of connective tissue. So it's not an endothelium, and it's not a muscle layer. Here is the external heart anatomy. We will go into details in the anatomy. You can see the left ventricle here. I will put the pointer. You can see the left ventricle, the left atrium. You can see the right atrium and the right ventricle. These are the major structure of the heart, and you can see the pulmonary artery going from the right ventricle, and you can see the aorta that is going from the left ventricle. It's more posterior here. You can see the origin, and you can see the coronary arteries here. You have the left system here. So we have the left anterior. This is the left main artery here that will divide in left anterior descending artery, and the left anterior descending artery will give rise to septal branches. So these branches will go to the interventricular septum, the space between the right ventricle and the left ventricle, and you can have diagonal branches. The diagonal branches that are here that will go to the lateral aspect of the ventricle, so to the lateral wall. And you have here the circumflex arteries, which originates as well from the left main coronary artery of the circumflex that will go also to the left aspect of the heart. And from the other side, from the other, it will make its origin from the aorta, from the right coronary cusp. You will have the right coronary artery. The right coronary artery will give blood supply to the inferior wall of the left ventricle here, and to the right ventricle, you can see clearly here. And you have the venous system as well. In every organ, we have arteries and we have venous return. So we have venous system as well. Okay. That moves the slides. I don't know why. Okay. So we said that the heart, we have the atrium, we have the atria, the right atrium and the left atrium. We have the ventricle, we have the right ventricle and the left ventricle. The atria will receive blood and will pump it to the ventricle. The ventricles will receive blood from the atria and will pump it to the systemic circulation. So that's how we differentiate between these two structures. And you can see here the circulation. So we will start by the right heart. So the right heart, we have the right atrium and the right ventricle. It's connected to the pulmonary artery. So the pulmonary artery will take blood from the right side, the ventricle and right atrium. And the right atrium will be provided with blood coming from the venous system. So a blood was rich in carbon dioxide, CO2. So the right heart will transmit CO2-rich blood to the pulmonary artery, and the pulmonary artery will go to the lungs. And in the lung capillary beds, we will have the gas exchange. So we'll exchange CO2. CO2 will go in the airways and will to the exterior environment, and we will take in its place the oxygen. The oxygen then will go from the capillary beds to the pulmonary veins. So in the heart, it's the opposite. The pulmonary artery, which is it's like a vein, it's rich in CO2, but the pulmonary veins are rich in O2. So it's opposite from elsewhere in the body here. the vein is rich in O2 and the pulmonary artery is rich in CO2. So it's the opposite. So the pulmonary vein will take blood to the left side of the heart, to the left atrium, and then the left atrium will pump the blood to the left ventricle, and the left ventricle will pump the blood to the aorta and to the systemic circulation in order to give oxygen and nutrients, as we said, to the different organs. Okay. So we have valves. So the valves, we have 4 valves in the heart. We have the atrioventricular valve, meaning that we have valves between the atria and the ventricles. These are the mitral valve. The mitral valve is the left-sided valve, which is a bicuspid valve. So it contains just 2 leaflets. It's called bicuspid. And we have the tricuspid valve, which is the right-sided valve between the right atrium and the right ventricle. It contains 3 leaflets. So that's why we call it tricuspid valve. And we have the valves between the ventricles and the arteries. So between the left ventricle and the aorta, it's the aortic valve, and it's the aortic valve is a tricuspid valve, and the pulmonary artery, pulmonary valve, which is a valve between the right ventricle and the pulmonary artery. So valves open as blood is pumped through. So when we are in diastole, for example, the mitral valve will open in order to allow the blood to pass from the left atrium to the left ventricle. And the aortic valve will open in systole in order to allow the blood to pass from the left ventricle to the aorta and to the systemic organs. And for example, the mitral valve in systole, it will be closed, because if the mitral valve is dysfunctional, it will remain open in systole. And usually in systole, the mitral valve should be closed. So if it remains open, we will have mitral regurgitation. So blood will come back from the left ventricle to the left atrium. Normally, we should not have this normally. So in case of dysfunctional valve, like this dysfunctional chordae, the chordae that's responsible for valve function, if they are dysfunctional, we might have backflow of blood instead of a forward flow. So as we said here, we have the atrioventricular valves. So the atrioventricular valve will pump blood from the left atrium to the left ventricle in diastole, and we have the aortic valve. So here, it will pump the blood from the left ventricle to the systemic circulation during systole, so during ventricular contraction. Okay. So sometimes we have, as we said, valve pathology. So we have incompetent valves. So the blood should always go in the forward direction. If the blood goes back from the backward direction, we call this a backflow of blood. So it's dysfunctional valve, and we call this regurgitation. So mitral aortic regurgitation, it's very common. Sometimes the valve is very stiff. So it's still conducting the blood in the forward direction, but it doesn't open well. So here the problem is that it doesn't open well. In incompetent valve, it doesn't close well. So here it doesn't open well, but the direction is still a forward flow of blood. So here, in that case, we will have aortic stenosis, and we will have workload increase of the heart. So we will have hypertrophy because the heart is pumping against a higher pressure. So the myocardial cells will increase in size in order to compensate this and try to bypass this obstruction. And the valves may be replaced. So now we can replace the valves. We can replace the valve by a biologic valve and by a mechanical valve. Biologic valve are usually used for older patients because they don't last for long. They last for an average 10 to 12 years, while younger patients are, if we need to replace their valves, we use usually a mechanical valve. We have also a new techniques like TAVR and transcutaneous valve replacement. We'll not go into details now, it's a different topic. So the heart and association with great vessels. So we said that it's associated with the aorta. It's directly connected to the left ventricle, and it's associated with pulmonary artery that leaves the right ventricle. It's always also associated with the vena cava. The vena cava is the largest vein of the body. The vena cava will transport the carbon dioxide rich blood from all the body to the right heart. So it will enter the right heart via the right atrium. And we have also the pulmonary veins. We said that the pulmonary veins will transport blood from the lungs, will transport oxygenated blood. We said that these veins are rich in oxygen, as opposed to all other veins in the human beings. So it will transport oxygenated blood from the pulmonary system, and it will enter the left atrium. So the coronary circulation, we know that the blood in the heart chambers does not nourish the myocardium. So the blood that's inside the cavity will not give nutrients and oxygen to the myocardium, because myocardial cells will also need oxygenation like any other cells in our body. So the blood in the heart chamber, the blood that comes to the myocardium is coming from the coronary artery. The coronary artery arises from the aorta. So the coronary artery will receive blood from the aorta during diastole. So the blood flow will reach the myocardium during diastole. And we also have cardiac veins in order to, like every other vein in the body, it will take the CO2 from the myocardial cells and it will transport them to the venous system and to the right heart. So now we'll go a bit into details in the real hemodynamics of the heart. So we can have rapid heartbeat, which mean when the heart beats faster, so we'll have inadequate blood flow and we'll start to have angina, because during tachycardia, the heart will require more oxygen, and we will be unable to provide the heart with this amount of oxygen. That's why we will have imbalance between demand of oxygen and providing of oxygen. So that's why we will have what we call angina. So we start to have chest pain. The heart is also a conducting system, so it has like electrical activity inside the heart. So there is electrical impulse that will originate in the atria, about we will call it the SA node. We'll see a picture later on, and it will propagate to the atria and to the ventricle in order to cause the ventricular contraction and the ventricular pumping of blood. So it's all based on the blood supply and electrical activity. So as we said, we have the electricity will be generated from a generator in the heart. It's like a generator that provides electricity to allow contraction. It's called the sinoatrial node. It's located in the right atrium. It's called the heart pacemaker as well. So it will induce the electrical activity and it will propagate the electrical activity to different parts. After that, we have the atrioventricular node. It's in the junction between the atria and the ventricle. It's like at the middle of the heart. Then after that, we have like the electrical current. We have the bundle of His and the bundle branches. So, and the Purkinje fibers. And the electrical activity will propagate in stepwise in this circuit I mentioned, and in order to allow for myocardial contraction. So here is an image. You can see the sinoatrial node we call SA node, which is the heart pacemaker. It's the generator of electricity to all the heart myocardial cells. It will propagate electricity in all directions to the left atrium and to the right atrium, and then we will reach the atrioventricular node, which is located between the atria and the ventricle. The AV node will continue to propagate the electricity. It can also generate a part of the electricity to the atrioventricular bundle, so it's the bundle of His, which is here. Then we have the bundle branches, which are after this bundle, and at last we have the Purkinje fibers that will go inside the myocardium in order to promote myocardial contraction. So it's like electrical current, so like the real electricity we use every day, and the electricity is generated by the movement of sodium and potassium and other electrolytes throughout the cardiac membrane. So the electrocardiogram will reflect this electrical activity. So we can quantify this electrical activity by doing an electrocardiogram. The electrocardiogram will show that we have formation of P wave. So the P wave meaning that the impulse is propagating across the atria. So we have an atrial depolarization and an atrial contraction. We see this on the ECG by seeing the P wave. Then after that, we have the QRS complex. So the QRS complex is when the electricity reaches the AV node and start to spread in the bundle branches and the Purkinje fibers. We see the ventricular depolarization or ventricular contraction, and this will be reflected on the ECG by the QRS complex. Then we will have at last the T wave. So the T wave will is the end of electrical activity in the ventricle. It's the period of relaxation of the ventricle. So the ventricle will relax. The relaxation of the ventricle will be reflected on the ECG by the appearance of a wave. We call it a T wave. So here is the ECG. You can see the P wave here. So the P wave, as we said, it reflects the atrial contraction, atrial depolarization. Then the QRS wave, which will reflecting the ventricular contraction or ventricular depolarization. And then we have the T wave, which will the T wave here, which will it is reflecting the ventricular relaxation or repolarization. So it's not depolarization here, it's repolarization. This is a normal ECG tracing. For example, here you can see a bit bizarre ECG tracing. This is ventricular fibrillation. This is a ACLS initiation. It's a cardiac arrest situation. So here you need to start the compressions and the ACLS protocol. So now moving to the pathology of the heart, of the hemodynamic of the heart. So we have damage when you have damage to the AV node. So the release of ventricles from controls will have slower heartbeat. So when we have damage to the AV node, so the impulse will not propagate from the SA node initially, which is a fast signal. So it will start to propagate from below the AV node. So from below the AV node, we can produce electricity, but it will be slower. So we'll have slower heartbeats. And this can lead to ventricular fibrillation because bradycardia, severe bradycardia can induce something we call polymorphic ventricular tachycardia or torsade de pointe, and this will lead to ventricular fibrillation because of the lack of blood flow that was induced by bradycardia. So bradycardia means low cardiac output, means low myocardial perfusion. It means increased risk of fibrillation. So tachycardia is defined as heart rate of above 100 beats per minute, and bradycardia is defined as heart rate that is less than 60 beats per minute. So or 50 beats per minute. Now I use personally 50 beats per minute to define bradycardia and not 60 beats per minute. So the cardiac cycle, so as we said, the atria, both atrias, the right atrium and the left atrium will contract simultaneously. They have to contract at the same time exactly because we see one P wave, and the P wave we see on the ECG is the contraction of both atria together, not just one atria, it's both atria. And they relax when the ventricles contract. So the atria relax when we see QRS in the ECG, it's the ventricular contraction, but it's as well the atrial relaxation. So systole is the contraction of the left ventricle, and diastole is the relaxation of the left ventricle. So systole and diastole have nothing to do with atrium. It's the ventricle function, the systole and diastole. So you can see here that ventricular filling, so blood will go from the left atrium to the left ventricle. This is the start of diastole. And diastole will end by something we call atrial contraction. So the first part of it is a passive motion of blood from left atrium to the left ventricle. So there is no contraction from the atria to pass this blood. But at the end of diastole, there's a portion of blood that remains in the left atrium. So we need the something we call the atrial kick or the atrial contraction in order to push the rest of the blood that remain to the ventricle. So we have the passive filling, which is the first part of diastole. Then we have the active filling, which is the atrial contraction of the ventricle. Then after that, we have a period of relaxation. The ventricle is filling up and increasing its pressure. And after that, we'll have when the pressure in the ventricle becomes higher than the pressure in the aorta, then the aortic valve will open. So it's a difference of pressure. When the pressure in the ventricle becomes higher than aortic pressure, the aortic valve will open in order to eliminate the blood from the left ventricle. And by this, we end systole, and this cycle will restart again by the ventricular filling and the atrial contraction. So it's a cycle. Now, if we want to talk about the cardiac output, so the cardiac output is very important physiologic and hemodynamic measurement. So the cardiac output is the amount of blood that is pumped by each side of the heart in 1 minute. So how to measure it? So it's all the blood that the heart can pump in 1 minute, not just one beat, it's a minute. So to calculate the cardiac output, we need to have the heart rate of the patient, and we need to have the stroke volume. The stroke volume is the volume of blood that is pumped by each ventricle in one contraction. So stroke volume, we can measure it by doing an echocardiography. For example, we can measure the stroke volume. And to calculate, so the stroke volume is the amount of blood that is pumped with each ventricular contraction. And we can multiply this by the heart rate, because the heart rate, we take it over a minute. So this will give us an estimation of all the blood that was pumped over a minute. And we call this the cardiac output. So for example, if a patient has a heart rate of 75 beats per minute, which is a normal patient, and have a stroke volume, so the heart with each contraction will pump 70 milliliters per beat. So this means that the heart can pump 5,250 milliliters per minute. So the heart can pump around 5 liters per minute. So this is the normal cardiac output for every human being. And the entire blood supply will pass through the body once per minute. So we'll have these 5 liters will circulate in all the body in 1 minute. And the cardiac output varies with demands of the body. For example, if we have an infection, for example, or a sepsis, so we need to increase cardiac output in order to give more nutrients and oxygen to the area that are affected. So cardiac output will respond to anemia, for example, to thyroid disease. So it's dependent on the body demands. Okay, and so as we said, the cardiac output is regulated by the nervous system. So we have the parasympathetic nervous system. So it's like a parasympathetic nervous system, for example, is when we are relaxing, the heart rate will drop, so the blood pressure will drop. But when we have a crisis situation, for example, we need to activate our sympathetic system, so the heart rate will increase. And as you said, the cardiac output is dependent on the heart rate. So when the heart rate increase, we'll have increase in cardiac output. So cardiac output is very dependent on the nervous system, on the sympathetic system, and on the parasympathetic system. Cardiac output is also related to exercise. So when you do exercise, activation of the skeletal muscle and respiratory pumps will cause increase in venous return. So increase in venous return will, in that case, cause increase in stroke volume. So stroke volume, we said it's the amount of blood that is pumped with each beat. So when we increase stroke volume, automatically we'll increase cardiac output. So during exercise, we have an increase in cardiac output. So cardiac output, as we said, is related to the sympathetic nervous system and parasympathetic nervous system and to physical activity. So normally in normal individuals, the stroke volume should remain relatively constant. So 5 liters per minute. It should remain relatively constant. And the changing in heart rate is the most common way to change cardiac output. So during sleep, the heart rate will drop for every one of us. So as during sleep, the cardiac output is lower than cardiac output during the day, because during the day, we have activation of the sympathetic system, we are moving, we are working, so for sure the cardiac output will be higher and during the day as compared to the nighttime. And so we said here sympathetic. We have also hormones like epinephrine, thyroxine, which is the thyroid hormone. And we have also exercise, as we said, and blood pressure. So the heart rate will drop if we have increase in parasympathetic nervous system. So when we're resting, when we're sleeping, we are activating the parasympathetic nervous system. It's a relaxation system, so the heart rate will drop. Heart rate as well will drop if we have a higher blood pressure. So as a reflex, heart rate usually drops when the blood pressure increases in order to keep the same stroke volume. And decrease in venous return will also cause the heart rate to drop, because during expiration, the venous return will be reduced. So we'll have a reduction in the heart rate as a compensatory mechanism. Okay. So in congestive heart failure, we have a decline in pumping efficiency of the heart. We have inadequate circulation, and we have a progressive coronary atherosclerosis, high blood pressure, and history of multiple myocardial infarction. So the left side will fail. If the left side fails, so we'll be in congestive heart failure. So the patient will drop his cardiac output, so the blood will accumulate in the heart. It will accumulate first in the left ventricle. Then, when the pressure increases a lot in the left ventricle, blood will start to accumulate in the left atrium as well. And as we said, the left atrium is linked to the lung system by the pulmonary veins. So the blood will start accumulating in pulmonary veins and will accumulate in lung capillaries, leading to what we call acute pulmonary edema. That's what we call vascular. We call increase in fluid overload. So when the left side fail, we'll have pulmonary congestion and suffocation. So the patient will present with severe dyspnea and desaturation. But when the right side fails, so when the right ventricle fails, for example, if we have myocardial infarction affecting the right coronary artery, in that case, we said that the right ventricle is linked to the inferior vena cava. The inferior vena cava is linked to all the venous system in the body, including the venous system of the lower limbs. So the first sign we see in a right-sided heart failure is peripheral congestion. So we'll see pitting edema in the extremities, in the bilateral extremities, and we can see ascites, as we said in the previous lecture. So we can see we can see liver dysfunction as a result, and so we will be in volume overload. Okay. So now the blood vessels, the vascular system. So we have a lot of we have arteries, we have arterioles, we have capillaries, we have venules, we have veins. This is the full vascular system of our body. So as you can see here, the arteries, you have the lumen of the artery inside. So you have the lumen, and the arterial wall is formed by a different structure. We have the endothelium, which is the most inner layer. We have the tunica media, which is the muscular layer, and we have the external layer, which is a conjunctive tissue layer. It's forming the outer layer. So the artery will be linked to a smaller divisions, like we call the arterioles, and the arterioles are linked to even smaller capillaries. But if we measure the surface area of the capillaries have the largest surface area, even bigger than the aorta, because we have a lot of capillaries, and if we measure them together, they will give us a huge surface area as compared to native vessels. So after in the capillaries, we will have gas exchange. So we'll give oxygen and nutrients to tissues, and with the venules, capillary venules, will take the carbon monoxide and the waste products from the organs and take them to the veins. The veins, like the arteries, are contain a lumen, so where blood will flow. But what is the difference of the artery? We have here valves. We have valves that will prevent blood from going into the backward direction. So it will go just to in the forward direction. And because in the, as you can see in the veins, the muscular layer that is responsible for pumping blood is a lot less than in the arterial system. So in the artery, we have the muscles that will promote pumping of blood, but in the veins, it's a lot reduced, the muscular layer. So we need those valves in order to prevent backflow of blood to the venous system and accumulation of blood in the venous system. So as we said, we have the inner layer, which is the endothelium. We have the smooth muscle layer, and we have the tunica axona, which is the connective tissue layer that is the outer part of any artery or vein. So we have difference. We said it in the previous slide. We have the wall of the arteries as the thickest because of the muscular layer, and the lumen of the veins are larger. But the veins contain low decrease in muscular layer as compared to arteries. And the wall of capillaries are only one cell layer thick to allow for exchange between blood and tissue. So capillaries are very thin. That's because we need to do the gas exchange at the level of the capillary. That's why the physiology created the capillary to be very thin in order to allow for this function. So movement of blood, as we said, veins, because they don't have a muscular layer, they use the muscular layer of the surrounding tissue. For example, in the lower limbs, we have the muscles that are surrounding the vein. So when we want to increase venous return, like during exercise, the muscle will contract and will push blood forward. And in that case, the valve will open. After the blood is pushed forward, the valve will close in order to prevent the blood from going backward. Capillary bed, as we said, consists of two types. We have the arterial capillaries and we have the venous capillaries, and we have vascular shunts inside. We have sphincters as well that opens and close in order to allow for gas exchange inside the capillaries. So oxygen and nutrients will cross to cells of organs, and carbon dioxide and metabolic waste products cross into the blood to go to the venous system. From the venous system, they will go to the heart. From the heart, they will go to the pulmonary artery, reaching the lungs, allowing for gas exchange. And in the lungs, they will come back to the left side of the heart by the pulmonary veins. So you can see here the diffusion of molecule in the capillaries. It's an osmotic, you have osmotic pressure, you have the intrinsic pressure inside. So it's like a passive diffusion of nutrients. So we'll have, because of the thin wall, we will have easy passage of nutrients and easy exchange of gas. We have vesicles that allow for nutrient exchange, and we have pores that allows for gas exchange. So it's a very complicated system, and a very system that's very, very organized in with all these details. So the vital signs, as we said, we have the pulse, we have the blood pressure, we have the respiratory rate, we have the body temperature. These are the basics hemodynamics that we need to check for all our patient. And if they are normal, all of the four vitals are normal, we have an efficient system. All that we talked about can be summarized by these four. So if the system that we talked about is dysfunctional, we'll have a dysfunction in the vital signs. So the pulse, we have all these points where we can measure the pulse. So you can have the radial, the brachial, which are the most used. The brachial is the most used. The femoral is used, especially during cardiac arrest, to detect if the patient has a pulse. We usually check the femoral, or we check the carotid artery pulse during ACLS cardiac arrest protocols. So the blood pressure, as you know, the blood pressure should be measured on enlarged arteries. So it will give us an idea of the systolic pressure and the diastolic pressure. So the systolic pressure is the pressure when the ventricle contracts, and the diastolic pressure is the pressure when the ventricle relaxes. We measure it. You all know how to measure the blood pressure. We will not go into details, but we use the stethoscope, or we can use the digital machines. You can use both. Both are incorporated in the guidelines. So we have, as we said, the nervous system can affect the blood pressure, the sympathetic system, the neurotransmitters like neuroepinephrines and epinephrines. We have renal factors, so there is a renin, angiotensin, aldosterone system. And heat can also cause vasodilation, so heat can drop the blood pressure as opposed to cold, which will cause vasoconstriction and will increase in pressure. And the various substances and chemicals can also affect blood pressure, the diet as well, especially diet rich in sodium. So the normal blood pressure, as we said, should be now in the recent guidelines, we should push to have a systolic blood pressure of 120 to systolic and less than 80 diastolic. Blood pressure that is above of that is now considered elevated blood pressure and should be monitored and treated aggressively. Okay, so I ended this topic. If you have any question, I'm ready to answer. No. And we will take a 5-minute break, I think, and we'll continue with the last topic. Do you have any questions? Okay. So we'll come back in 5-6 minutes. Okay, so I will start with the last presentation of today. Are you hearing me and you're seeing the slides, right? Okay, great. So the last presentation for today is a presentation on myocardial infarction. So myocardial infarction is the complete blockage of the coronary artery that will lead to myocardial cell death due to complete absence of blood flow and oxygen delivery to tissues. So we have a necrosis in the myocardium. So the learning objective of this session is to describe the initial evaluation and triage of patients presenting to the acute coronary syndromes, and how to risk stratify this patient to see which patient should receive immediate revascularization and which patient can wait. So, and what is the optimal reperfusion therapy for STEMI patients, what medical therapy to use, and what type of revascularization to use. So for any patient presenting, to the hospital with acute coronary syndrome, every patient with acute coronary syndrome for sure should be hospitalized. We can't discharge a patient from the emergency department to his home if he has acute coronary syndrome. This is medical error and will lead to consequences, ethical consequences. So the first 12 to 24 hours, we have to eliminate ischemia. So if we're suspecting ACS, acute coronary syndrome, we need to hospitalize the patient for 24 hours just to make sure his symptoms are related to ischemia. And after that, if we confirm ischemia, the patient should stay 24 hours after revascularization to maintain, to do medication maintenance, because as you know, medications can cause serious side effects, especially cardiac medications, and to monitor for complications post-myocardial infarction, because we have a lot of complications post-myocardial infarction, and to modify the behavior and the lifestyle. So it's a very essential 24 hours in these patients. After that, the patient can be discharged home, and we should see the patient 4 to 6 weeks later for post-hospitalization follow-up. So it's either discharge home or he can go to a rehabilitation center. But the doctor needs to see the patient 4 to 6 weeks later, either the cardiologist or the family doctor or the GP. So he needs to see any of them. So as we said, the most essential part from this, what we said is you have to eliminate ischemia. This is the most essential topic to discuss. Ischemia is the reduction in blood to tissues, and it can be classified as acute ischemia or as chronic ischemia. So ischemia is the reduction of myocardial oxygen demand, as we said. So and increase. To treat ischemia, we need to increase myocardial oxygen supply and to decrease myocardial oxygen demand. So we have a lot of medication to do that. We have the beta blockers, the diuretics, the renin-angiotensin aldosterone inhibitors, and we need to do the reperfusion. So by doing a coronary angioplasty and placing a stent immediately in order to reverse ischemia. So reperfusion therapy in acute coronary syndrome. How can we complete the reperfusion? It's either by unblocking the blocked artery. So we need to do an invasive procedure like reperfusion therapy, like stenting, for example, stenting the blocked artery, put a stent, or we need to prevent. We need to prevent acute reocclusion, because when we put a stent, there is a risk of stent thrombosis after the stent. So we need to put the patient on antiplatelet medications and anticoagulant just to prevent this acute complication of stent thrombosis. Okay. So how can we overcome coronary occlusion in ACS? We have two options. We have either mechanical, so we have invasive approach. Invasive approach is PCI, so stenting, or we can do coronary artery bypass graft. But usually in cases of STEMI, ST elevation MI, and non-ST elevation MI, we usually do PCI because PCI is more rapid and it gives you results faster than CABG. We keep just CABG for a very complicated case where PCI fails, or we fail to put a stent, for example, then we refer the patient to CABG. If the hospital we work in does not have PCI capability or CABG capability, we can use medical therapy for acute coronary syndrome. We can use fibrinolytics. Fibrinolytics are very powerful medications that will work on the coagulation cascade in order to dissolve this clot that occluded the artery. But fibrinolytics are only used for ST elevation myocardial infarction and can't be used for unstable angina or for non-ST elevation myocardial infarction. So just for ST elevation myocardial infarction. The fibrinolytic agents that we have, so the medical therapy, we start by the medical therapy. We have fibrin-specific agents like alteplase and staphylokinase. We have a non-fibrin-specific agent like streptokinase, anistreptase, and urokinase. The most common used one nowadays is tenecteplase, which comes from alteplase. Usually it's the only used one. It should be the only used one, but because it's the most effective and the one with the least side effects. So if we need to use fibrinolytic agents, if we don't have PCI capability in our hospital, it's better to use tenecteplase fibrinolytic. So antiplatelet therapy, as we said, we need to use, so we need to put medical therapy in order to prevent stent thrombosis after we put a stent. So to inhibit the propagation of the thrombus as well, and will minimize thrombotic complication after the PCI procedure. So for the antiplatelet agents, we have oral agents and we have IV agents. For the oral agents, we have the aspirin. You all know the aspirin is the most commonly used drug in cardiology. And you have the P2Y12 antagonist, we have three drugs: clopidogrel, which is sometimes called Plavix, ticagrelor, which is called in the hospital Brilinta, and prasugrel. So we have these three options in addition to aspirin. We need to put these two drugs together. So either one of the P2Y12 antagonists with aspirin for all patients presenting with acute coronary syndrome. This is class 1 recommendation. We have some IV antiplatelet agent like the GP2B3A inhibitors. These are a receptor found on platelets. So these are very potent platelet inhibitors. So they inhibit platelet aggregation. We have the apixaban, the eptifibatide, and the tirofiban. The tirofiban is also called in hospitals the agrestat. So this one is sometimes used. We will see the indication to use the drug. We should not use it for all patients. So to compare now the P2Y12 inhibitors, we said we have clopidogrel, prasugrel, and ticagrelor. So we should know that just ticagrelor is an active drug. So the drug will be absorbed in its active form. So we take the drug in its active form. Clopidogrel and prasugrel are not active drugs, they are prodrugs. So they need to be absorbed and metabolized by the GI system in order to become effective. And the onset of action of clopidogrel is 2 to 4 hours. So it's a long onset of action as compared to ticagrelor, for example, which is 30 minutes of action. So it's more rapid, the ticagrelor. So the duration of effect, so to have the maximum platelet inhibition effect, we need 3 to 10 days for clopidogrel, 5 to 10 days for prasugrel, and 3 to 4 days for ticagrelor. So ticagrelor here is more potent than the two drugs in this aspect. If we need to do a major surgery, for example, a life-saving surgery, the anesthesiologist will ask us that we need to stop the antiplatelet drugs in order to be able to proceed with the anesthesia and with the surgery. So as you can see, the effect of the drug will last for 5 days after stoppage in case of clopidogrel, prasugrel 7 days, and ticagrelor for 5 days. So it's a lot. So sometimes we can't wait to delay the surgery this much. And the first dose of this medication, when we should start this medication, we should start with a loading dose. We should give 600 milligrams of clopidogrel. So it means 8 tabs because each tab is 75 milligrams. As for the ticagrelor, which is called Brilinta, we should give a loading dose of 180 milligrams. So we should give 2 tablets. And then after that, we continue with either clopidogrel 75 milligram, 1 tab daily after placing the stent. And we continue, if we use ticagrelor in the beginning, we should continue with a tablet of 90 milligrams twice a day, so morning and night. So the anticoagulant therapy. So we now talked about the antiplatelets therapy. We said here we have the antiplatelets therapy. We still have the anticoagulant therapy in addition to the antiplatelets therapy. So the anticoagulant will inhibit generation and propagation of red thrombus, where platelet activation has initiated thrombus formation. So anticoagulant will not work on platelets. It will work just on thrombus formation. The thrombus formation was initially caused by platelet aggregation. So we need to target the platelets by giving antiplatelet like aspirin and clopidogrel, for example, and we need to target the thrombus formation that resulted from platelet activation by giving anticoagulant therapy. So for the anticoagulant, we have the heparin, we have the unfractionated heparin, which is, it's now less used as compared to previous years. And we have the low molecular weight heparin, which is the enoxaparin. We call it Lovenox in some hospitals, but it's a low molecular weight heparin. It's given in sub-Q injection, while the unfractionated heparin is given in an IV injection. So this anticoagulant agent will work on coagulation cascade, and they will facilitate antithrombin 3 activity in order to dissolve the thrombus that is already formed. So the most commonly used is unfractionated heparin and enoxaparin. So nowadays we rarely use the others. We just use these two drugs in the acute coronary syndromes. So when is the timing for reperfusion? As we said, acute coronary syndrome can be divided in two categories. You have ST elevation, myocardial infarction, and non-ST elevation myocardial infarction, and we can make the difference based on the clinical feature and on the electrocardiogram feature. So we detect an ST segment elevation on the ECG. STEMI is an emergent situation. We should not wait. When we diagnose STEMI, we have 90 minutes to transport the patient to the cath lab in order to do the PCI and to put the stent. So once the patient arrives to the hospital, we have the door to balloon, we call it a door to balloon procedure. We have 90 minutes. It's an emergent situation, and every hour of delay will cause an increase in mortality. As for non-ST elevation MI, so here it's less urgent. So we have two approaches. We have the early invasive approach, which is divided in emergent. So like STEMI, we'll see when we do it. We have the urgent early invasive approach, and we have the early elective. So early elective means that we should not do it immediately when the patient presents. We can wait a few days or 24 hours. We will see later on. And the revascularization should be based on ischemia grade. We'll see that on the later slides. So, as we said, the most important part is to eliminate ischemia. So any patient that presents to acute coronary syndrome, a STEMI or NSTEMI, to the hospital. So we need first to check if the situation is emergent, it's urgent, or it's stable. So emergency, we said, STEMI patient or STEMI patient should be classified as emergency situation and just a part of non-STEMI patients. After that, we need to check when did the symptoms start, because this is very important for the treatment. We need to check if the patient came to the hospital by himself or he came by the ambulance, for example. So after doing all that, we will have a risk stratification. So we will have a risk of estimation of risk of death, risk of reinfarction, risk of heart failure, and risk of treatment. Because as you know, treatment have a lot of side effects, especially it can cause bleeding, it can cause, we'll see the side effects as well in this presentation. So as we said, STEMI, it's an emergency. So we just have to choose, it's either to do PCI or to do lytics. But we have just 120 minutes from the start of symptoms. So from the start of ischemia to open the artery. And we have 90 minutes from when the patient arrived to the ER to open the artery. So it's very time sensitive, and every delay will increase in mortality. So for NSTEMI, so NST elevation acute coronary syndrome. So as you said, we have three categories: emergent case, urgent case, and stable case. So we risk stratify. And in order to risk stratify, we have to calculate scores. We have the TIMI score, we have the GRACE score, and we have the pursuit score, which help us to classify the patient if the patient is an emergent situation, urgent situation, or stable situation. So these three scores, they will predict short-term mortality, and they will predict recurrence of MI after the initial event. But if we need to simplify our life and don't calculate the score, we can just at the bedside stratify the risk. So if patient is old, has an old age, it's a high risk patient. If the patient have refractory symptom despite medical treatment, so this is a high risk patient as well. If the patient develop heart failure, so as a complication of MI, the patient start to have pulmonary edema, lower limbs edema, that are refractory to therapy as well, this is a high risk. If we have a lot of comorbidities like diabetes, CAD, PAD, hypertension, this is also an increase in risk. And if we're seeing dynamic changes on the ECG, for example, and ST elevation, first, we don't have ST elevation on the ECG, but sometimes the patients can develop ST elevation. This is an increased risk, and If the troponin is increasing we do cycle of troponin, so we repeat troponin after 1 or 2 hours. We have now the hypersensitive troponin, which can detect myocardial infarction just a few minutes after the event, and it will increase significantly 1 hour if we repeat it. So now our laboratories are well equipped. So we don't need to calculate scores. We just can ask these questions. If we have these features combined, we can consider STEMI as emergent situation as well, and we treat it as we treat STEMI, so emergent revascularization. So, which perfusion therapy to choose? As we said, we had the fibrinolytics. We discussed fibrinolysis before. We said we have PCI and we have cabbage. This slide is about the efficacy of fibrinolytic therapy. So in this study that was published in 2017, it was discussed in the Mayo Clinic Cardiology Board review as well. This study contained 58,600 patients from 9 randomized trials on fibrinolytics. As you can see here, the fibrinolytics chart on this graph is the blue one, as I compared it to the placebo. So you can see that fibrinolytics as compared to placebo for sure had mortality benefits. So it drops mortality as compared to placebo in all types of myocardial infarction. But in case of inferior myocardial infarction, the difference between fibrinolytics and placebo was not very big, but it was statistically significant because it has a p-value of less than 0.05. So it was statistically significant to reduce mortality in all cases, except for the case of ST depression. So that's why we said we're not allowed to use fibrinolytics in case of ST depression. It should only be used in case of ST elevation. And new onset bundle branch block is an equivalent of ST elevation. So it's contraindicated to use it in ST depression because of this study that has a very huge sample size. So the guidelines were relying on this study. So it's not indicated for for non-ST elevation MI. So you can see here fibrinolytics versus time. So when we use fibrinolytics in the first hour, you can see that we drop mortality from 80% to 40%. But after the first hour, so after the third hour, if we use fibrinolytics, it's not effective. You can see that you have flattening of the curve. We don't have any additional mortality benefit. So we'll have increase in mortality if we use fibrinolytics after 3 hours. So we should use it in the first hour if possible, if we want to use it. So greatest benefit in one first hour and minimal additional benefit after 3 hours. But we can't use fibrinolytics for everyone. I'm talking here about STEMI patients. Even for STEMI patients, we can't use this therapy for everyone. We have absolute contraindications like any prior intracranial hemorrhage. So if a patient had a history of intracranial hemorrhage, it's an absolute and contraindication to use it. If the patient has a intracranial cancer neoplasm, because as you know, intracranial neoplasm has a higher risk of hemorrhagic transformation. So if the patient started bleeding in his head, this will lead to mortality. So they will not benefit from fibrinolytics. If they did an ischemic stroke in the last 3 months, it's also a contraindication because ischemic stroke still can transfer to hemorrhagic, can have a hemorrhagic transformation till 3 months after the stroke. So if we suspecting as well aortic dissection, if the patient complaining of chest pain radiating to the back, it's preferable not to use fibrinolytics, because if we have aortic dissection and we use fibrinolytics on aortic dissection, is 100% mortality rate from bleeding. If the patient have an active bleeding, for example, active GI bleeding, it's also a contraindication. Or if we have a facial trauma within a significant facial trauma within the past 3 months, it's contraindicated to use it. So here they compared fibrinolysis to PCI, to stenting. So the fibrinolysis is in yellow, and the stents are in the blue. So as you can see, this trial contained 7,739 patients, and you can see there's a benefit of PCI as compared to lytics. So PCI is better as compared to lytics for 30 days death, for reinfarction, and for cerebrovascular accident. So PCI is always better than lytics if it's available, but the problem is that PCI is not available in all areas, in all countries, in all hospitals. So we tend sometimes to use fibrinolytics because of unavailability of PCI. So each 30-minute delay in primary PCI results in a 7.5% relative increase in 1-year mortality. So this is a huge increase in mortality. So just 30 minutes delay will cause 7.5% increase in mortality after 1 year. And if you see that if we have more than you have, for example, 36 minutes delay after onset of events, we will increase mortality by 12%. So fibrinolytics are always available. All hospitals should have fibrinolytics, but not everyone is eligible because we said it's just for STEMI, and even for STEMI patients, we have contraindications. And it can cause complete reperfusion in just 55% of patients. So not everyone will benefit even if we give the drugs. And 10 to 20% will have reocclusion. As compared to primary PCI, so everyone is eligible for primary PCI. There's no absolute contraindications to do a primary PCI. And as compared to fibrinolysis, here we have more than 90% reperfusion rate, while in the fibrinolysis we have 55%. But the problem is that it's not available everywhere. So a lot of small hospitals doesn't have PCI. A lot of rural areas, for example, mountains, we'll have a lot of people living in mountains, for example, they don't have PCI in the hospital. And there's a chance of reocclusion in just 5% as compared to 10 to 20% in fibrinolytics. So it's very beneficial. It's more beneficial than fibrinolytics. So when we see a patient, with ACS, we should first check if we don't have a PCI in the hospital. We need to check if he's lytic eligible, so if he's eligible for fibrinolytics. If he's not eligible for fibrinolytics, so if he has a contraindication, we need to transfer him to another hospital that contains a primary PCI team, so to contain a cath lab. So we need to transfer him either by ambulance or by helicopter. If the patient is lytic eligible and in our hospital we don't have a primary PCI, so we need to check the symptoms, this duration, and the anticipated time to move him to a PCI capable hospital. So if the symptoms started less than 3 hours, okay, we said the lytics can give us benefit if we use them the first 3 hours. So if the symptoms started less than 3 hours and the anticipated duration of transport to a PCI capable hospital is less than 2 hours. So in this case, it's better to transfer him to a PCI capable hospital because just 120 minutes. So we're still near the range we put at the beginning. But if the symptoms have started less than 3 hours but the PCI capable hospital is very far, so more than 120 minutes long duration of transport, in this case, we need to do lytics and transfer him even if we do lytics. So we need to give lytics, then transfer him even if the hospital is very far, because we said with lytics we have only just 55% chance of reperfusion. So it's not 100% like PCI. But if the symptom duration are 3 to 12 hours long, so they started a long time ago, so here there is no benefit with fibrinolytics. So we need to transfer the patient to primary PCI capable hospital, even if the duration of transport is long, because here there's no benefit in fibrinolysis, because after 3 hours we lose all the benefits. So we said that we need, even if we give fibrinolytics, we then has to transfer him to a PCI capable hospital in order to make sure he has restored his flow. And if he didn't, we need to do an emergent revascularization, invasive vascularization by stent angioplasty. So to summarize, as we said, if we have a PCI capable hospital, you have a STEMI, and we have a PCI capable hospital, we need to initiate antiplatelet therapy in the emergency department. We need to give aspirin and one of the three P2Y12 receptor antagonists like ticagrelor, prasugrel, and clopidogrel. And we need to also give GP2B3A, which an IV antiplatelet just in specific situations, not for everyone, this one. But the first two should be given for everyone. But this one should be only given if we suspect a large thrombus burden. So if we do the coronary angiography and we see a large thrombus and we think that the stent will not be able to put a stent inside this thrombus, in that case, we need to start to give tirofiban, which is called commercial name is agrestat. And if we didn't treat patients well with our P2Y12 inhibitor, so we gave him a wrong loading dose, so we can then initiate an IV antiplatelet in that case. So we just in these two situations, this drug should not be used in any other situation because it has increased risk of bleeding. Okay, so so as we said, in addition to antiplatelets therapy, we should give anticoagulation therapy in order to support PCI, because we said that the anticoagulants that we discuss here are to prevent stent thrombosis, that will put the stent in the PCI procedure, so to prevent stent thrombosis and to decrease the platelet activation in order to prevent further thrombus formation. So the anticoagulant will be used in order to support PCI, in order to remove the thrombus, in order to make the stenting procedure more simple. So we usually use heparin, unfractionated heparin, or we use low molecular weight heparin, as we said before. Fondaparinux is not very used. It's class 3 recommendation. You should not use it. And bivalirudin is not very used as well. So in case we're talking in the place where we have PCI capability. So we're in a hospital that will for sure put a stent. We need to put all this treatment together with the stent. But let's imagine we're in hospitals that doesn't contain a PCI cath lab, so we can't put a stent. So we are only left with fibrinolytic agent. What should we give in addition to these to the tenecteplase fibrinolytic drug? We also need to give antiplatelets here in order to reduce platelet activation. But here the dosages are different, and the only P2Y12 we can use in case of using fibrinolytics is clopidogrel. We can't use ticagrelor or we can't use prasugrel, so we can only use clopidogrel here. And the loading dose here is dependent on age, as is not like the loading dose we use in PCI capable centers. So the loading dose should be only 300 milligrams. So we should only use 4 tablets if less than 75. And if the patient is above 75, we should not give a loading dose. We should only give 1 tablet, because combining P2Y12 inhibitor in addition to tenecteplase, the fibrinolytic agent, will increase a lot the risk of bleeding and will increase the mortality. The mortality will become higher as compared to the myocardial infarction itself. So we should be very careful by dosing these medications. And we need to avoid using the IV antiplatelet, the GP2B3A, tirofiban. We should not use it in case of fibrinolysis. We should use anticoagulation if we give fibrinolysis as well. So the same, we have unfractionated heparin, enoxaparin, and fondaparinux. So we should use them for at least 48 hours duration after fibrinolysis. So we should keep them for 48 hours duration at least. So here is the third situation where we're in a non-PCI capable hospital, in a STEMI case. So we decided to use fibrinolytic, but the fibrinolytic failed. So we didn't have revascularization. The patient remained in chest pain. The troponin continued to rise. So we're still in a bad condition, and the patient is a high risk, and he's still in ischemia. So in that case, we're obliged to transfer him to a PCI capable center. So even if we pass the time, 2 hours time that we said at the beginning, we don't have any other option. We need to transfer him to another hospital. And in the other hospital, so we said we need to avoid the GP to BCA because we already gave fibrinolytics. We need to use aspirin and clopidogrel. Prasugrel should not be, can be used sometimes, but we prefer to use clopidogrel in case if we have previously used fibrinolytics. Okay, so aspirin, clopidogrel, and anticoagulation after fibrinolytics. So here is we need also to we said here that we also need to give anticoagulation in addition to antiplatelets, even if we did fibrinolytics or if we did PCI. So in both cases, we'll have to give anticoagulation. So now we move to non-ST elevation acute coronary syndrome. So as we said, for all ACS cases, we need to admit them to the hospital, and after that, we need to stratify them. It's either we do an early invasive strategy or we can delay it based on the questions we asked and on the scores. So the ischemia guided approach and non-ST elevation and unstable angina should look for we should stratify the risk by checking the ECG and checking the heart echocardiogram. So if we have a normal ejection fraction, in that case, this is a low risk patient. If we have negative troponin or they didn't rise a lot, this is also a low risk procedure, low risk patient. So in that case, we can wait. But if the patient is stable but has increased risk of events, for example, if the patient has positive troponin, if he has active ECG changes, if we have a drop in his ejection fraction, if he already did a PCI or cabbage board, here we are in front of an increased risk of events, and in that case we should do an invasive strategy. So we should do an early revascularization. We should not wait, like the ischemia guided approach we discussed here in a low risk patient. Here we need, in these circumstances, we need to do an invasive strategy earlier than what we do for low-risk patients, especially that patient can have hemodynamic instability and refractory angina. These also are criteria to push, in addition to the criteria we discussed on the bottom of the slides, to push for an early invasive strategy, an early PCI strategy. So for the invasive strategy, with the early invasive, we said on the previous slide, for this condition, we have 24 hours in order to perform the PCI. But sometimes when we have other conditions, we need to perform it immediately, like the case of STEMI, within 2 hours. So if the patient has severe chest pain and is refractory despite nitrates that we give and despite the anti-pain medication, even with morphine, patients still have pain. This is a high risk patient. If the patient develops severe heart failure with acute mitral regurgitation, so this is also a very high risk patient. If he develops hemodynamic instability, if he develops low blood pressure, if he develops sustained ventricular tachycardia or ventricular fibrillation, and he went into cardiac arrest and we started ACLS. So here it's an invasive strategy. We cannot wait at all. We need to do immediate invasive within 2 hours of presentation to the emergency department. So we said we have the delayed for low risk within 25 to 72 hours. So we can stabilize the patient, do the echo, do the ECG, do all the tests before doing the invasive procedure. The early invasive is within 24 hours, and the immediate invasive is within 2 hours, and the immediate invasive in STEMI and unstable angina is equivalent to ST elevation. So we need to treat the same way that we treat ST elevation, except that in these conditions, we're not allowed to use fibrinolytics. We just can do PCI for non-ST elevation. It's contraindicated to use fibrinolytics in non-ST elevation MI. So we can rely on scores. So early invasive, if it's a GRACE, we'll not go into details, but you have a GRACE score. If it's above 140, we then can push for early invasive, so within 24 hours. Okay. So now how can we treat these patients? So we decided that we have a non-ST elevation MI, and we decided that we will do, for example, a PCI in the next 24 hours. But before the PCI, all these patients should be on antiplatelet therapy. So we should give oral antiplatelets and like aspirin for everyone, and in association with P2Y12 inhibitor like clopidogrel or ticagrelor. So we can use also the IV, which we discussed before, the GP2B3A inhibitor. We use it just when we have a large thrombus. So just for that, we don't use it unless we have a very large thrombus and we think that we will not be able to put the stent in this diseased vessel. And we should not forget to add a proton pump inhibitor in patients with a history of GI bleeding. So PPI should not be used in everyone, just patients that are high risk for GI bleeding or had a history of GI bleeding before. We should not use PPI for every patient that is on aspirin. So we said we said combining two antiplatelets with GP2B3A in just certain circumstances. And we need to give anticoagulant therapy as well. So we need to give, like the case of STEMI, we need to give double antiplatelets with anticoagulant. We have the same medications here: unfractionated heparin, enoxaparin, fondaparinux, which is not used. I never use it in my hospital where I work, so we just use enoxaparin and unfractionated heparin. Because fondaparinux was associated with thrombus formation on catheters at PCI. So when we're putting the stent, we use catheters. So there's a risk of thrombus formation inside the catheter, and thrombus will migrate to reach distal part of his coronary arteries. So it should not be used. So when we find that the STEMI has a low risk, so we don't do a PCI immediately, we just put him on oral double antiplatelet therapy and anticoagulation. The duration of anticoagulation is for 48 hours, or if we don't put a stent, we need to keep the anticoagulation for the duration of hospitalization up to 8 days maximum. So there is no need to anticoagulate the patients more than 8 days. But the aspirin and the P2Y12 inhibitor, we should keep them for at least a year or 6 months. Okay. So we're repeating the same stuff here. So here, for example, if we decide to, for example, we don't need to do PCI, we have to do CABG. So as we said in the previous lectures, sometimes when we have indication for CABG, so when we have multiple vessel disease, you have 3 vessel disease, if we have left main disease with diabetes, for example, in that case, we need to do CABG. We can't do PCI in that case. So if we do CABG, we can't continue unfractionated heparin and just stop it before the surgery. But for the others, for example, enoxaparin, we need to stop it 12 hours before CABG. And when we stop it, we should continue unfractionated heparin till the time of the surgery. Okay. Okay, so for the ACS treatment, as we said, we need, after giving the treatment, we need to modify and monitor ischemic heart disease. So we need to monitor for complication of acute myocardial infarction, because as you know, we have a lot of complication post-MI, like arrhythmias, ventricular arrhythmias, fatal arrhythmias. We could have left ventricular wall rupture, so we can have the rupture of the heart, will cause a tamponade accumulation of blood in the pericardial space, which will cause cardiac arrest post-MI. So there's a lot of things that we should avoid, like steroids, NSAIDs, and hormone replacement therapy during MI. We should never give steroids or NSAIDs with MI because these drugs will increase the risk of stent thrombosis after putting a stent. So we need to avoid steroids and non-steroidal anti-inflammatory drugs. So for example, there's a lot of patients that take NSAIDs for pain. We need to stop this medication during acute myocardial infarction. We need to add medical therapy. As we said, we need to add dual antiplatelet therapy. So DAPT is dual antiplatelet therapy. So aspirin plus a second P2Y12 inhibitor. We need to put a high-dose statin. So high-dose statin is atorvastatin, 80 milligrams, or rosuvastatin, 20 to 40 milligrams. And we need to add beta blockers for all patients with MI, and we should continue it for 3 years after MI. And we need to put angiotensin converting enzymes or angiotensin receptor blockers. It's recommended for all patients with MI, regardless of regardless if the patient is in heart failure or not. Even if the patient is not in heart failure, we need to put ACE inhibitor or angiotensin receptor blockers. And if we still need to add another medication, we can add an aldosterone antagonist to better control, for example, the blood pressure. So, but these 3 drugs are more effective in LV dysfunction, but we need to use them even if we don't have LV dysfunction because they will prevent remodeling. So after MI, there will be a continuous inflammatory process in the myocardial cells. So we will have continuous remodeling of these cells. So we need to stop this process, and this will delay the progression of the disease and will decrease mortality. And we need to modify behavioral changes like smoking cessation, like diet, and we need to do cardiac rehabilitation after the myocardial infarction. So after we do all of this, we need to do all these steps. If we miss a step, it's considered a medical error. It's a harmful, as we are doing harm for the patient if we don't do all these steps. After that, and after putting the stent, we can discharge the patient home. And we need to continue outpatient follow-up for aggressive secondary preventive measures. So we need to see the patient, as we said, 4 to 6 weeks later, in order to see if the patient is compliant with his medication, if he's continuing his behavioral therapy, like smoking cessation, like diet, like exercise. So we need to check all these things. It's a very, very complicated structure. And we need a multidisciplinary team. We need a cardiologist, we need a family doctor, we need a general physician, we need a dietitian, we need a nurse, we need a heart specialist nurse. So it's a system, and it's very costly for the hospitals and for insurances and for the ministry. So it's a very if we follow it and do what the guidelines said, we will have benefit for our patient for sure. So therapies to wean away. We need to stop pain medication as soon as possible. We should not keep the patient on IV nitroglycerin if he's not in pain. Nitroglycerin is given to relieve pain. Morphine as well is very used in acute myocardial infarction because patients will have severe pain, so we need morphine in order to reduce the pain. But we should not use excessive dosages because this medication can cause dependence. And oxygen is only used for patients that have a saturation less than 90%. There is no need to give oxygen in myocardial infarction for patients that have an oxygen saturation above 90%. In fact, if we give a lot of oxygen and we increase the FiO2, so we put it on a ventilator, for example, and he is not in need, this will cause lung toxicity and will aggravate the condition and will, if we put him, for example, on a BiPAP, for example, it will cause hypotension and will worsen his myocardial infarction. So it's preferable not to put MI patients on BiPAP or on CPAP devices in the acute settings. So after that, we said that we need to put him on dual antiplatelet. We need to continue with the dual antiplatelet for 1 year. The statins should be controlled for life. We should continue statin therapy for life. We should never stop statin. And after 1 year of that dual antiplatelets, we can withhold one of the 2 antiplatelets. So we usually keep aspirin for life. And the beta blockers, we said we use them for 3 years post-acute myocardial infarction, unless we have other reasons to use beta blocker for life, like heart failure. And ACE inhibitor, ARBs, and aldosterone antagonist are also used post-MI for life, even if we don't have LV evidence of LV dysfunction. Okay. So sometimes we have other comorbidities like AFib, mechanical valves, venous thromboembolism, hypercoagulability. So in these cases, we need to continue, in addition to the antiplatelet, we need to continue the anticoagulation, because we said before the anticoagulant should be stopped. Just you should use it just in the hospitalization, and if we put a stent, we should stop the anticoagulant directly after the stent. But in these conditions, we need to anticoagulate. So if we have a mechanical valve, if we don't anticoagulate with an anticoagulant, there's a risk of valve dysfunction and valve thrombosis. So it's a mortality benefit to anticoagulate here. And diabetes, for sure, should be treated, because diabetes can accelerate intrastentary stenosis and need for revascularization. We need to avoid IV beta blockers. There's no indication to use IV beta blockers in myocardial infarction. IV ACE inhibitors are also not used, and calcium channel blockers also should not be used in the acute settings. Like nifedipine, it's a calcium channel blocker that we use to treat high blood pressure. So as we said before, we need to stop corticosteroids, stop NSAIDs, except for aspirin, because as you know, aspirin is a non-steroidal and also an anti-inflammatory drug, aspirin. And we need to not use hormone replacement therapy, especially in females that use hormone replacement therapy to prevent pregnancy. So we should advise these patients that they should stop hormone replacement therapy. So we need to emphasize on smoking cessation, on diet, and on risk factor assessment, and on cardiac rehabilitation. So it's very important to send the patient to a cardiac rehabilitation center in order to treat him well. Okay. So we said that we need to keep DAPT for a minimum of 1 year. And we need to use anticoagulant if indicated. Just in these 4 situations, we can use anticoagulant with DAPT. And all these drugs should be used with caution. And glucocorticoid are now in the guidelines that is class 3, so it's not advisable to use glucocorticoids and NSAIDs, as we said. So this is the initial figure I showed you. We said that the patient should come back to us 4 to 6 weeks post-hospitalization, post-myocardial infarction, but we need to keep seeing the patient on a long term, for lifelong. So a patient with myocardial infarction should see his doctor frequently. So every 6 months to 1 year, or before if he develops new symptoms. So it's very important for secondary prevention of new cardiovascular events and of other complications of myocardial infarction and complications due to medications. We need to also always follow these patients. So we said before that we have to do revascularization. We have either PCI and either CABG. But the most used procedure is PCI, but sometimes we're obliged to do CABG in certain situations. For example, if we look at this figure, for example, if we have 1 or 2 vessels, okay, so just 1 or 2 vessels without proximal LAD disease, so without proximal main vessel disease, in that case, PCI is class 1 recommendation. So PCI is better than CABG here. It's a mortality, we have mortality benefit with PCI. So if you have just 1 to 2 vessels without proximal vessel disease, it's class 1 recommendation to use PCI and not CABG. If we have a left main, if a proximal left main disease, like you said in the previous discussion, when the syntax score is low, they are both equal, so we can do both. But if the syntax score increase, you can see there's benefit with CABG. CABG is class 1 as compared to PCI, which is class 2A in syntax score, which is intermediate risk. And when the syntax score is above 32, the PCI becomes class 3, so it's not recommended, and we should use CABG. So here we have a left main lesion. You can see the lesion here, the circle on the artery. I don't know if you're seeing it. I will use the laser pointer. It's this lesion. Okay. So when we have three vessel disease, so not left main disease and not proximal LAD disease, you have three vessel disease. Here also we use the syntax score, but here we have different numbers. So if the syntax score is less than 22, it's the same PCI as CABG. But when the syntax score increase, you can see that PCI is class 3 here in the intermediate syntax, so we should use CABG, and in class 3 as well in the high risk group, which is syntax above 32. So PCI is not recommended when you have three vessel disease and myocardial infarction. So it's better to do CABG in that case. So CABG is class 1, unless the syntax score is low, we can try both. So if we want to switch, for example, if a patient develops a side effect on a medication and we need to switch from P2Y12 one to another, so clopidogrel to ticagrelor, both are P2Y12. In order to switch, we need to stop clopidogrel and give a loading dose of the second medication. So we need to give the loading dose again. Same from clopidogrel to prasugrel, and same from ticagrelor to clopidogrel. We need to give the loading dose of clopidogrel LD, which is the 600 milligram or 8 tablets. There is no data to switch from prasugrel to ticagrelor, so this is not recommended, and there is no guidelines regarding this. So we should not try to switch from prasugrel to ticagrelor because there's no study on this topic. So now the last thing we will discuss today is patients that are on antithrombotic therapy, so on dual antiplatelet therapy, and they need to do elective non-cardiac surgery. So let's say I have a patient that did myocardial infarction since 1 month. He's still on 2 antiplatelets because he said we need to continue the antiplatelets for 1 year. And he developed, for example, appendicitis, acute appendicitis, and the surgeon told us that we need to remove it surgically, remove the appendicitis surgically. So what to do in this case? So in case of elective non-cardiac surgery, so the surgery is elective, so it's not a non-urgent surgery. Usually appendicitis is urgent, but let's say we have an orthopedic surgery which can be delayed. So we classify it as elective non-cardiac surgery. We have 2 types of stent. If the stent was a bare metal stent, we usually don't use any more bare metal stent. So in case of bare metal stent, we can hold antiplatelet drugs 30 days after replacement of stent. So no need to skip the drugs for 6 months or 1 year. But if we put the second type of stent, which is the most commonly used, drug-eluting stents, which is the contained medication, this is sirolimus or the everolimus stents. In that case, we can't do the surgery. We should delay it for at least 6 months. We're not allowed to stop the antiplatelet drugs before 6 months. But if the surgery is major surgery and there's mortality related if we don't do the surgery, then we can delay the surgery for at least 3 months and then try to stop the antiplatelets. So if the risk of the delay is higher than the risk of the stent thrombosis, so in that case, we can wait 3 months in order to do the surgery. And that's it. So thank you for listening. And if you have questions, I'm ready to answer you.
Thank you, Dr. Antoine.
Okay.
Any questions? Okay. يعطيكم العافية and see you tomorrow, inshallah. Thank you, Dr. Antoine.
Thank you. See you tomorrow.
See you tomorrow.